supported us to make this. Some of our community pharmacies, we have some of our industrial juggernauts, we have also some of our hospital decision makers in the audience, and we also have some as well online. So it's important that they are able to provide us with information and so we can take advantage of some of the promotions they have. Am I correct? Am I correct? Excellent. So let's please make welcome Reals Pharmaceuticals. Let's make them welcome now. Thank you.
Good morning, everyone. I'm Monica from Reals Pharmaceutical. Today, most of our products, not most, all our products' prices has changed. But for today, for our most of our product has gone up, in short, all. But for today, our Reflex, our Pheniramidol, our Rosutoro Silvastatin 10, our Acycle Plus, will be given at a discounted price. Unlike the normal price, it's been sold out. So when you come to our stand, these three particular products will be given at a discounted price. Then others, depending on the quantity you are taking, you will also get a discounted price. Because we believe that a lot of us have not gotten the information that our prices has changed. So we're using this as an avenue to relate to everybody that the prices has changed and you are getting a special offer as our beautiful mommies and daddies today. Thank you. So they are bringing some of the products. I will just show a little light on them and just show you the product. Thank you.
The Pharmaceutical Society of Nigeria, PSN, Lagos State Branch, presents the Annual Pharmacy and Scientific Week 2023. Theme: Innovative Approach Towards Ensuring Medicine Security, the Place of Local Active Pharmaceutical Ingredients, API Production in Nigeria.
Like I said, these are Reflex, Pheniramidol, for pain, muscle spasm, back pain, all kind of pain. So for today, you are getting it at a discounted price. These are Rosuvastatin 10. Today as well, you are getting it at a discounted price. These are our Acycle Plus, Cyclophenac Paracetamol. Today, you are getting it at a discounted price. Then this is our Marmalades for our breastfeeding and nursing mothers. Today as well, you get it at a discounted price. And one of our beautiful, loving products, Barhabs Coffee. Today as well, you are getting it at a discounted price. Thank you.
The Pharmaceutical Society of Nigeria, PSN, Lagos State Branch, presents the Annual Pharmacy and Scientific Week 2023. Theme: Innovative Approach Towards Ensuring Medicine Security, the Place of Local Active Pharmaceutical Ingredients, API Production in Nigeria. Under the distinguished chairmanship of Sir Anthony Akime, FPSN, FNA Farm, FPC Farm. Guests of honor: Air Commodore Pharmacist David Babalola, FPC Farm, Deputy Director, Doctrinal Development, Air Welfare Center, Nigeria Air Force, Abuja. 2. Mr. Olawale Musa, Permanent Secretary, Ministry of Establishment, Lagos State. Pharmacist Ibrahim Babashiru Ahmed, FPSN, Registrar, PCN. Special guest: Prince Pharmacist Wali Oladigbolu, ACPN Chairman. Pharmacist Dr. Ken Onuebu, FPSN, Chairman, NAIP. Keynote address: Pharmacist Olumide Akitayo, FPSN, FPC Farm, FNA Farm, FNIM. Chief host: Pharmacist Professor Cyril Osifo, President, Pharmaceutical Society of Nigeria. Host: Pharmacist Oyekunle Babayemi, Chairman, PSN Lagos State Branch. Masterclass series sponsored by Emzo Vaccines and Pfizer starts 9 a.m. prompt on Wednesday, 6 September 2023 at the PSN Lagos Secretariat, Ogudu, Lagos. Grand opening ceremony, date Thursday 7 September 2023, venue Sheraton Hotel, Ikeja, Lagos. Time is 10 a.m. prompt. Red carpet starts by 9 a.m. This hybrid event will be streamed live on PharmaStream TV YouTube channel. Subscribe today for instant notification when event goes live. Announcer Oluwatosin Adeyemi for PSN Lagos. The Pharmaceutical Society of Nigeria, PSN, Lagos State Branch presents the Annual Pharmacy and Scientific Week 2023. Theme: Innovative Approach Towards Ensuring Medicine Security, the Place of Local Active Pharmaceutical Ingredients API Production in Nigeria. Under the distinguished chairmanship of Sir Anthony Akime, FPSN, FNA Farm, FPC Farm. Guests of honor: Air Commodore Pharmacist David Babalola, FPC Farm, Deputy Director, Doctrinal Development, Air Welfare Center, Nigeria Air Force, Abuja. 2. Mr. Olawale Musa, Permanent Secretary, Ministry of Establishment, Lagos State. Pharmacist Ibrahim Babashiru Ahmed, FPSN, Registrar, PCN. Special guest: Prince Pharmacist Wali Oladigbolu, ACPN Chairman. Pharmacist Dr. Ken Onuebu, FPSN, Chairman, NAIP. Keynote address: Pharmacist Olumide Akitayo, FPSN, FPC Farm, FNA Farm, FNIM. Chief host: Pharmacist Professor Cyril Usifo, President, Pharmaceutical Society of Nigeria. Host: Pharmacist Oyekunle Babayemi, Chairman, PSN Lagos State Branch. Masterclass series sponsored by Enzo Vaccines and Pfizer starts 9 a.m. prompt on Wednesday 6 September 2023 at the PSN Lagos Secretariat, Ogudu, Lagos. Grand opening ceremony, date Thursday 7 September 2023, venue Sheraton Hotel, Ikeja, Lagos. Time is 10 a.m. prompt. Red carpet starts by 9 a.m. This hybrid event will be streamed live on PharmaStream TV YouTube channel. Subscribe today for instant notification when event goes live. Announcer Oluwatosin Adeyemi for PSN Lagos. The Pharmaceutical Society of Nigeria, PSN, Lagos State Branch. The Pharmaceutical Society of Nigeria, PSN, Lagos State Branch presents the Annual Pharmacy and Scientific Week 2023. Theme: Innovative Approach Towards Ensuring Medicine Security, the Place of Local Active Pharmaceutical Ingredients API Production in Nigeria. Under the distinguished chairmanship of Sir Anthony Akime, FPSN, FNA Farm, FPC Farm. Guests of honor: Air Commodore Pharmacist David Babalola, FPC Farm, Deputy Director, Doctrinal Development, Air Welfare Center, Nigeria Air Force, Abuja. 2. Mr. Olawale Musa, Permanent Secretary, Ministry of Establishment, Lagos State. Pharmacist Ibrahim Babashiru Ahmed, FPSN, Registrar, PCN. Special guest: Prince Pharmacist Wali Oladigbolu, ACPN Chairman. Pharmacist Dr. Ken Onuebu, FPSN, Chairman, NAIP. Keynote address: Pharmacist Olumide Akitayo, FPSN, FPC Farm, FNA Farm, FNIM. Chief host: Pharmacist Professor Cyril Usifo, President, Pharmaceutical Society of Nigeria. Host: Pharmacist Oyekunle Babayemi, Chairman, PSN Lagos State Branch. Masterclass series sponsored by Enzo Vaccines and Pfizer starts 9 a.m. prompt on Wednesday 6 September 2023 at the PSN Lagos Secretariat, Ogudu, Lagos. Grand opening ceremony, date Thursday 7 September 2023, venue Sheraton Hotel, Ikeja, Lagos. Time is 10 a.m. prompt. Red carpet starts by 9 a.m. This hybrid event will be
Well, you can't point. So heartburn actually occurs because of regurgitation, hyperacidity, and then what is in the stomach trying to get into the esophagus and back to the mouth. And so sometimes we call it gastroesophageal reflux disease to confuse the patient so they don't know what we're talking about. But then it's just heartburn, they know it to be. It occurs when the stomach acid moves there to the esophagus, and the symptoms are there. You have a sour taste in the mouth, burning sensation in the throat, pain that radiates around the heart area because the stomach curves and it's very close to the heart. So the nerves, the pain can actually even be felt up to the way to the back. And that is why when a patient is having heartburn or pain, they cannot use one finger to say the pain is here or here. They use the whole palm. It's here. It's here. That's how they describe their something. And so you can even have cough and then pain in the chest. I was going to show this, how this, the closeness of the trachea and the root to the stomach. See how close they are? So when acid is poured to the stomach and then some of it wants to go back, you feel the pain right there, and the patient is complaining of heart problem. Now, so heartburn is different from ulcer. Ulcer is a wound, open wound, but this one is not on the outside. It's right there in the stomach. You know, there is a mucous layer that covers it. Otherwise, the digestive fluids, whether it's ptyalin or acid or whatever is used to digest the food, all of them are right there secreted. Otherwise, it will have been digesting the stomach itself. But there is a mucous layer that protects the stomach. But then when there is a wound, all those digestive fluids can get to that wound. And so that's what causes stomach ulcer. So the symptom is burning stomach pain, just the same thing as hyperacidity. So it's a heartburn that was after eating fatty foods, because fatty foods are very difficult to digest. You know, fatty food, emotion must take place, and there must be a lot of peristalsis trying to digest that. So there's more secretions, and then it's more intense. So when there's food there, it increases. Then there will be belching and bloating because of gases produced. Then there will be pain that might be worse in the night because you are lying down, sometimes between meals. So medication to ease pain and help us to heal are what we prescribe. All those antacid, all those cimetidine, ranitidine is no more there. Omeprazole, ransoprazole, and the rest of them. So you have all those to take care of the ulcer. Okay, so there is hiatal hernia. Hernia is when there is less pressure somewhere, and then the fluid passing through it causes a bulge somewhere. So if the diaphragm helps the lungs to expel air, so they move up and down. So because the stomach is also there, that has some effect. So it can cause a weak portion to have this happening, and so stomach acid can then spill into the esophagus because of the diaphragm that is pressing on it. Acid and food may come back into the esophagus, trying to come out through the mouth. Sometimes some patients actually vomit, so the thing gets complicated when they are narrating their ordeal. So you are getting more and more convinced with something else. So hiatal hernias can raise the chances of heartburn also. Esophageal spasm, just spasm. So you have the way peristaltis work, pushing from one segment to the other one. So the food from the throat to the stomach will pass through those tiny muscles, and then they squeeze, and that's what we call peristalsis, segment by segment. Sometimes these muscles tighten up when they shouldn't. So they're supposed to be like traffic lights on a very long street. If there are about 10 of them in civilized countries, they are synchronized. As you are driving at about 60 kilometers per hour, before you get to the next one, it's changing to green. The next one changing to green. That is how peristalsis is supposed to work. So sometimes it doesn't work that way. One of them might just not perform the way it should be. So the spasm gets discordant, and then it can be painful, and there is diffuse esophageal spasm, we call that. Some of these muscles tighten up when they shouldn't. They are most common from people 60 and above, but not that it can affect the others, but it's most common among them. So there is pain, there is trouble swallowing, and then when you have trouble swallowing, we think of something else again, and we'll be thinking of Strepsil and antiseptic lozenges and the rest of them. So sometimes they say they feel like something is there. Some of us want to induce vomiting. So all those confusions are there. So when this happens, I think it should be taken as an emergency so that something else could be done. They could take an X-ray quickly and diagnose better. Then there is esophagitis. When we say itis, that's inflammation of something. Bronchitis. It's not loud enough, okay? So this inflammation of the esophagus itself. So the lining of the esophagus, when it gets inflamed, then you have difficulty in swallowing. You can see the relationship with the last one we just talked about. There may be pain behind the breastbone. The feeling like something is stuck in the chest. Again, these symptoms will probably be worse when eating. So it's getting confused with right from heartburn to ulcer to hiatal hernia to esophagitis, about the same symptoms all over the place. So pain reliever may help. Treatment depends on what's making the esophagus to be sore. And then the most common cause is, again, what we call heartburn, gastroesophageal regurgitation disease. Pleuritis. Do we call it pleurisy? Americans like to call their own one way or the other. Both mean the same anyway. So if you hear pleuritis, it's inflammation of, we know what it is now, and then pleurisy. Inflammation of the tissue lining the chest and surrounding the lungs. So this is not pneumonia. The inflammation is inside the lungs. Pleuritis is outside. What's enveloping the lungs? So during COVID, we remember that in the early stages, all over the world, once a patient goes in for oxygen, then they die because there is already inflammation in there, and the speed at which air is pumped in there actually makes the case worse. And then since that's through where they breathe, there's no other way, then there is likely to result in death. Depending on where the inflammation is, it may feel like heartburn. Again, this one feels like heartburn. It will get worse when breathing, when coughing, or when sneezing. Some people also run fever. Treating its cause is the solution. So what's causing it? We have to look at that. Oh, success. Yeah, I pressed the wrong button. It didn't work. Now, pneumonia, or is it pneumonitis? Those are another confusing thing. So pneumonitis is the general term for inflammation of the lung tissues itself. So this is what I was talking about, ventilator-associated pneumonia. That was what was killing people in the early stages when we were not learning enough, we were not knowledgeable enough about using this oxygen pumping in a ventilator there. So the pneumonia is acute pneumonitis. So inflammation that is caused by by bacteria is what is causing pneumonia. But pneumonitis is the general term for everything. So infection inflames the alveoli, and it could be in one lung, it could be in both, and the alveoli may fill with the fluid or pus that resulted from that. Those symptoms: mild fever, cough, chills, shortness of breath, chest pain, reduced appetite. And if you look at that again, These are the symptoms presented. You are thinking of malaria. Some people actually treat both malaria and typhoid. They're not touching the real thing. So that's how confusing all these things are. Now, atherosclerosis. Then there's atherosclerosis. Atherio. If you don't look at it very well, you think it's the same word. What is it talking about? Athero and then atherio without H. Atherosclerosis is a chronic inflammation condition that involves buildup of plaque in the arteries or anywhere in the body. So your cholesterol level, that's what is this. And so now blood to pass through becomes problem, and that's why we use all these anti-cholesterol medicines to help in hypertension. Now, arteriosclerosis, hardening and stiffening of the arterial wall itself. Not that anything blocks it. With age, those reflect, very flexible blood vessels. When there is blood to expand, to let it go or not, their own is stiff. It just stays there. So blood finds it difficult to pass through. So that is arteriosclerosis. Then both of them make blood flow to be very difficult, and so that results in increasing BP. Then congestive heart failure. So what does it mean that the heart fails? Does it mean the patient is dead? Because if the heart fails, that's death. But then that's not it. It's just that the heart is not doing its job the way it should. Because it's one single pump with one stroke, pumps blood out and also pumps it back to his heart. Just one stroke like that. So if the force is not enough, or the complex valves you have in the heart, because you have 4 chambers in there, very complex. One will open to take in. At the same time, maybe the third one is also opening, but the one in between will have to close to receive it first. When this one closes, that third one will close, and then the middle one will open for that one to go in there. That now goes to the lungs. So if the one in the lung cannot go out, then you have a problem. Then the patient cannot breathe well. The places, the alveoli where oxygen should be exchanged is blocked with fluid already. That blood is there, or whether oxygenated or not, is there. It's in the lung. So the patient cannot walk long. He cannot do anything exertive, and then he's already tired. So then when they sit down, the one in the leg, gravity pulls it down. It's not forceful enough to prompt it back. So they have swollen leg. So you have pedal edema, and those are the kind of things that happen when you have congestive heart failure. Congestive in the sense that the lung is filled with fluid that is not going out of it. More and more stay there. Actually, after diagnosis of CHF, patients don't live more than 2 years, except they have some intervention done. Even the best of intervention, not that they will live 5 years after that. So the prognosis is very bad. So they have, by symptoms, shortness of breath with activity or not. If it gets worse, while they are sitting down, they are already finding it difficult to breathe because the lungs are filled with fluids. So exchange of oxygen is almost impossible. Then the legs, like I said, because gravity pulls it down. For the heart to pump and for it to come, it's like you have a 3-story building, and then you have one pump right there, down in the borehole. And then to get water to that top is a problem if the pump is not good enough. So they have reduced ability to exercise. They wheeze like asthmatic patients. Some doctors can diagnose asthma from there again. So it gets complicated. Then swelling of the belly area, you'll be thinking of ascites again. Because when you stomach, they'll be thinking of how to get fluid out of, not knowing that it's somewhere else. Swelling of the belly area, nausea and lack of appetite. Malaria comes to mind. And difficulty concentrating or decreased alertness because oxygen is not getting to the brain sufficiently. So they get confused also. So CHF can be life-threatening, and the prognosis is very bad. Now, angina. We are going to see similarity again between angina and that congestive heart failure. This one is a coronary heart disease. the heart that is doing the pumping itself is not getting its own share of oxygen. So maybe atherosclerosis is already around the heart. So for those tiny, tiny vessels to supply oxygen to the heart itself, there is a problem. It's not getting enough. And so it happens when insufficient blood flows to the heart. It's easy to confuse heartburn with angina. Heartburn tends to happen after meals or when lying down. That is the difference. But angina is opposite. It's more common after being active. After being active. So because the oxygen, after being active, the muscle demand oxygen and the heart has to work faster and supply more. And because it's not getting its own share, then it becomes painful. So the feeling in the chest is more like tightness or squeezing. That's what they complain of, than the burning pain of heartburn. That's how you still distinguish it. Angina seems to mean risk for a heart attack. Chest pain or tightness is an emergency. We must refer quickly. So heart attack. Okay, cardiac arrest. So where the police arresting the cardiac, most serious cardiac arrhythmias is what is called cardiac arrest. That means there is ventricular fibrillation, there is cardiomyopathy, there is severe hemorrhage, there is hypoxia. That's not enough oxygen getting there, electrocution, drug overdose, and all this suddenly happen. And so if the heart rhythm is not okay, then you have a problem. The heart stops pumping blood, and then normal breathing can stop. So the symptoms are fatigue and dizziness, shortness of breath, then you have nausea, chest pain, heart palpitations, loss of consciousness. So most of these symptoms, we have talked about them again in the other areas that we have just talked about. So this is where your ECG comes in, and the expert can read that and see where the problem is, and then we'll have antiarrhythmic drugs. Now, heart attack. We said heartburn stays in the chest or throat, but blockade of oxygen supply to the heart itself is another one. You know, if we want to relate that to stroke is when a small vessel in the brain is probably blocked, which is ischemic, or it bursts, which is hemorrhagic stroke. So either of them, where that blood is supposed to get to, it's not getting there. And that's why that area of the brain where it is going to can just die quickly, because brain cells die too quickly. And so when that happens, the area where that brain is controlling is also, the effect is lost. And that's why after, if they survive, maybe one leg cannot be moved, maybe one arm, maybe both, maybe from waist down and stuff like that. That's because the brain, each brain area controls one area or the other. And so just because that area doesn't get oxygen for less than 30 minutes, 1 hour, 2 hours, it might be permanent. It's how soon they get help that determines what will happen later. So symptoms will be squeezing or aching pressure, shortness of breath, cold sweat, feeling dizzy without warning. Women are more likely to also have an upset stomach or throw up. So heart attack is an emergency, just to say that. Okay, I think I have a pointer now. Yeah, just like this. All right. So I was trying to compare stroke. This is hemorrhagic stroke. It's blocked and blood cannot go. It's supposed to go there. This might be atherosclerosis. Now a blockade and it cannot go. And this is hemorrhagic stroke. It bursts. So where it is going does not receive blood. The same thing in the heart is happening. So you can see blockade there. These are the vessels supply the heart itself. So if it can't, it will go back, and so the heart cannot do its job very well. Sorry. Gallstones. Gallstones are not stones. So they are just pebble-like bits of cholesterol or digestive fluids that end up in the gallbladder itself. So we say people should drink plenty of water, and when they take drugs like cotrimoxazole, they should drink plenty of water. and that's why this can happen. But the symptoms of this is that there is likely an ache in the center and right side of the belly. That's the symptom. But for heartburn, the symptoms can last for hours, and they can happen after a fatty meal. But there could be pain behind the shoulders or rib cage in case of gallbladder stone, because the nerves are there. The pain can radiate to anywhere. So it's an emergency case also, and it should be quickly referred. Now, esophageal cancer. Of course, cancer is another story on its own. Long-term heartburn can raise the odds of getting the cancer. If it keeps up despite treatment, and endoscopy may have to be necessary so that they can see exactly what's going in there, and then they have to go in there and take a sample for biopsy. So other symptoms are trouble swallowing. Now, trouble swallowing, we have to be very serious when we are looking at that. It's not just ordinary. It might not be just ordinary problem. Weight loss, coughing and hoarseness are very common. Chest pain or pressure. This is also an emergency. So in summary, we said, first, we must do no harm. If you cannot help the patient, don't make the case worse. Refer quickly if you are not sure of anything. The hospitals have means of more proper investigation, and the problem is that some of the medical officers, not specialists in each area, might delay and think they can do something, and they waste more time. So it's not only to us. So we need to speak professionally and know which term we are talking about, so that we don't get confused with the terminologies. And because if we get confused with terminologies, we are likely to get confused with our conclusions. Abdominal cavity houses most of these vital organs. Many of them are there. The heart, the kidney, the pancreas, the liver, the lungs, even the kidneys are very close there. Now for women, the uterus is very close by, and all those things. So that's where most of the problem we have, we are always pointing to that area. So the nerves linking these organs to the brain and muscles are in there. Symptoms and locations of symptoms of pathologic organs located in the stomach are therefore very, very similar. Like we saw, many symptoms, we do not rely on history and symptoms alone, because many of those symptoms are confused. They are the same. There is no difference between your typhoid and malaria, although it's becoming alarming now. Anybody has malaria, you see people buying just anti-malaria and ciprofloxacin. Now, that is ugly. The malaria itself was not diagnosed. They just feel they have it, and immediately they want to buy anti-malaria and ciprofloxacin. Why? It's just in case. You don't treat anything just in case. But that's what's going on. The doctors are guilty of that, and community pharmacists are also guilty of that. My slide is gone. Oh, it's the back. Now, okay, I'm the one that pressed it. We need to understand this is even if for referral purposes, because if we want to refer, we must tell where the patient is going, what we suspect, what we have done. But if we will be making a mess of ourselves if we say the wrong thing. So we want to just talk more about sleep apnea. Everybody needs a good uninterrupted 6-hour sleep. So if you don't sleep well, you have dysrhythmia, which is one of those problems we just talked about. And your BP can also rise if you don't sleep well. Sleeping well but not breathing well for a few seconds at a time causes sleep apnea. That means oxygen not getting into your system, and that's a problem. And what that can lead to is that you can't sleep. That's insomnia. Then you'll be gasping for air, and that's where snoring comes in. Then you wake with dry mouth and morning headache, because when all night you are gasping, of course. So apnea causes snoring about 50 to 200 times a night. So those who snore, not like when they just stand, they just snore all night. No. They snore for a few times and then peace. They sleep for a while. Then again, and they snore and snore and again peace. All of it, all they woo. So they can do up to 200 times a night. And that's because of sleep apnea. They need air. The air is not coming. So snoring is a cardiac symptom of sleep apnea itself. So there are tests that can be done in the hospital and test kits at home to cure, but lifestyle changes can help. So if you have sleep apnea, you have to take care of that. Thank you very much. We may want to contribute because this lecture was in July. Most of the people were there. Maybe you didn't have a chance to discuss. Let's just brainstorm. I'm not an expert in any of them. Anybody has something to say or question? Don't be shy. Should I call the...
Good morning, my chairman, distinguished chairman, past chairman, distinguished colleagues, ladies and gentlemen, good morning. My name is I.J. Anuku. I'm lost but found anyway. Okay, thank you so much, sir, for the lecture. I just want to make a contribution based on what he has said. I practice more in the industry, but because I'm a pharmacist, in my church, they say they want to do outreach. So they found me a pharmacist. I wanted to dodge. They say you're a pharmacist. But I'm not so used to community practice anymore. Unfortunately, I turned out to be the only pharmacist there. So I must go and do that job. Okay? So it's the experience I had there that I want to share with you. So there were the doctors, the nurses, and then the pharmacists. Eventually some people joined me. But as the doctors were diagnosing, one thing was coming out strong. Please, one house. One thing was coming out strong. They were seeing a lot of patients with high blood pressure. Some with, overweight, obese, and all of that. So the doctor will say the pharmacist should please give them advice on how to manage, lifestyle modifications and all of that. So let me just bring out this because he mentioned it here for the benefit of those who consult us as pharmacists. I noticed that in Lagos, people don't sleep. So when we see those high blood pressure and we're asking them, are you a known hypertensive and all of those? And then you ask, okay, lifestyle modification, you need to reduce salt intake, you need to exercise, you need to sleep well. All of those people that had high BP, they were not sleeping well. So just to call our attention, either for ourselves, for our family and friends, or those who are in the community, those who come to see us. I'll ask many people, when do you sleep? Some will say they sleep by 11, 12, 1. When do you wake up? 4, 5, 6. So many of them don't get up to 5 hours sleep. A particular case of a young lady, well, not so young, she's married though. She says she's having a weight on her head every day. I say, when do you normally notice? Every day. Say, but it's lighter. Maybe by weekend it's lighter. So it tells me something. And I say, he said that when she comes back, there's a lot of traffic. She stays in traffic for 4 hours. She doesn't sleep well. She wakes up early to leave again. So I said, madam, you have to relocate from that your place. So as it turned out, the husband was there. I said, you have to look for enough money to move because this woman may have some challenges. So it is when she rests on Friday, on Saturday, by Sunday, it gets lighter. By Monday, she goes through the challenges again. So please, those who are in the community or in the hospital, try to look out for this and advise people to try to sleep well. Thank you, sir, for your wonderful lecture.
Hello, please. This is emergency announcements. The owner of LSD31GW, please come and repark. Someone wants to move out. LSD G31, a Nissan Jeep. Please, kindly bear with us. Thank you. It's urgent. Urgent, please. LSD 31GW, a beautiful Jeep. Please come and repark. Thank you.
Hello. I want to believe a protocol has been established. If none was established, let us ride on the one that was presented by our professor. So can we just give him another round of applause? So we'll quickly go to the business of the day. Our sponsors, Swiffer. Let's welcome pharmacist Ayedun Kolade Arenas Plus. Thank you. We're not clapping. Next year we are coming to them again. No?
Good morning, everyone. Like he has said, my name is Kolade Ayedun. I'm a pharmacist. I'm here with my colleague, Chinelo.
Melidem Chinelo. I'm also a pharmacist.
Yeah. So wonderful to be amongst you guys, everybody. I just want to quickly mention some of our products that are on promo. We are still going to do a proper presentation if there is that time for us very soon. But we have our Arenas ranges, our Artemida Lumefantrine. We have our Arenas ranges on promo. buy 14 packs to get one free. We have our Suprafem, which is for our pregnant women. We have this is our Suprafem for our pregnant women. We have our Arenas ranges, anti-malaria. We have our Dirax, our Piperquine combination. And we also have our Pyros Combi for the ulcer patients. It's coming also for buy 14 packs, get one free. We have our Ocefix 60 ml and 100 ml, the Cefixime 60 ml and 100 ml, also coming for buy 14, get one free. We have our Ceftriaxone, 2 grams, 1 gram, our Ocezone, we call it Ocezone, 2 gram, 1 gram, coming for 19 packs, buy 19 packs, get one free. We have our Clabetic, metformin and glibenclamide combination. We also have our Swibetic on promo. For our metformin glibenclamide, if you buy 4, you get one free. We have our metformin glipizide combination, Swibetic. You buy 7, you get 3 free. We have our metformin, ordinary metformin. You buy 8 packs, you get 2 packs free. We have our Swidem, that's our Zolpidem for the treatment of short-term insomnia, onset insomnia. We have that, buy 6 packs, get 3 free. We have our amlodipine ranges, the 5 milligram, the 10 milligram. You buy 8 packs, get 2 free. For the by hundreds only, not for the by 30s. But for the by 30s, you buy 8 packs, you get 2 free. The 5 milligram, you buy 9 packs, you get 1 free. We have our Relieve Rapid, that's our naproxen sodium. You buy 5 packs, you get 1 free. We also have our Super Kids. Our Super Kids syrup for our kids. Our multivitamins for our kids. You also buy 9 packs, you get 1 free. I will not want to take much of your time again. If you come to our stand, we have our stand there. Once you come, we'll give you more insight on the products we have. And Swiffer, Swiss Pharma Nigeria Limited. Yes, Swida. We have our Swida. We have our Talen, Bromazepam. We have our Swida, the SP combination. We have every other thing is there. We have a whole lot of products, but these are the major products that are on promo. Thank you very much.
Thank you.
Thank you very, very much.
Can we do better for them, please? The next is New Heights. Joy. Did you say Joy or Joyce? Joy. What's the difference between Joy and Joyce? Multiple joy. Let's clap for New Heights.
Good morning, distinguished pharmacists. I'm delighted to be in your midst today. My name is Joy Debanaria from New Heights Pharmaceutical. So I'm just going to broaden your knowledge about some of our ranges. You already know about Omron. Okay, refresh. Let me use the right. So let me refresh you about some of our new ranges. So we know about the M2367, but right now we have the newest range of products, the Omron Complete. Some of you that were at panel 15, you came to our stand, and many of you saw how we displayed the product, and majority of people bought it. So the Omron Complete is a blood pressure monitor that has ECG attached to it. So when you're checking your blood pressure, at the same time, it's giving you a heart scan. So you download your Omron app on your phone. So when you check your blood pressure, the result is sent straight down to your phone. You can share with your healthcare practitioners, either the doctors or the nurses or the pharmacists. So with that, they can help you monitor the heart condition. So atrial fibrillation, bradycardia, and all the rest of it will be detected if the patient actually has this. So it's actually meant to be used at home. For patients, some patients don't even... Some of them, maybe they do blood pressure once in a month or once in a 2 months. But if they have something like this, it will prompt them to constantly check what their heart is reading at every point in time. They will also have the Omron Evolve. The Evolve is the tubeless Omron. So for those who actually want to go out for workouts and the rest, you can carry it around. It doesn't have a tube. Usually the regular Omron has the tube that will tell you to place it on the brachial artery. This one does not have any of such rules. You can place it anywhere on your arm, and it gives you an accurate result. It's simple and easy to use. Then for the M1 Basic, we understand the economic situation of Nigeria, that some people cannot actually, people coming to your premises, they really want to get blood pressure monitors, but they cannot afford the premium ranges. So we have the one that can fit into any pocket, the M1 Basic. It doesn't have memory, but you can also download the Omron app, where you save all the memory you get from that machine. And it's the cheapest of all. Many of you have been patronizing. We still need more patronage on that. Then for the health check ranges, we have the PSA, the prostate-specific antigen test cassettes. As we all know from research, it has been proven that prostate cancer is the second most frequently diagnosed cancer in the whole world. Over 1 million yearly has been recorded. So what do we do to help people to test ahead of time? So if it's something that can be prevented by using medication before it leads to cancer, then we advise them. But when you get to that critical condition, what do we do for them? We are advocating people should encourage patients to keep testing from the age of 40 and above for men. We encourage them to test. The cassette is not so expensive, it's cheap, it's affordable, and it's something that can be done at the comfort of their homes. It's on our stand. When you come, we'll show it to you. We also have the Triple H viral. What we mean by Triple H is a cassette that tests HIV, hepatitis B, and C at the same time with one blood sample. So when patients come into your pharmacy and say, oh, I want to buy Postinor 2, it means they've had unprotected sex. What do we advise them to do? Please, can you check your status? For men too, they're always coming to get sex enhancement supplements. We also advise them. Some people come randomly to say, I want to check my HIV status. Then we'll advise them, why not get this cassette that does 3 at the same time? Last month, a patient came in, walked into the one pharmacy where my rep supplied. With the symptom he mentioned, the pharmacist suspected that it could be hepatitis B. But when he checked, the man came out with HIV and hepatitis B at the same time. So some people are having all of this and they are not aware of it. So we want you to help us talk to them. if it means we're giving you a banner at your stand, at your premises, for people to know about this problem, we'll do that. But we want to help people know that they should be aware of hepatitis B. People know more of HIV. People are not aware of hepatitis B, and it's deadlier because it affects the liver. And once the liver shuts down, that is the end of life. So that's what we're advocating, that please, we want to create this awareness to people around us. Then for the pharma ranges, we have the evening primrose. Many of you have it on your shelf. For women, it can be used from the age of 13 for teenagers up to menopausal women. It balances up hormone. So women who have been using evening primrose at their tender age will not come up with those postmenopausal syndrome at the end of the day when they get to menopause. So it balances up the hormones in their body. It also has the GLA that moisturizes the skin. Some women buy it for beauty, and at the same time it's doing so many other works in their body for them. We have also the brain liquid for children to enhance their intelligence and their cognitive sense. Some children are very restless. They don't sit in one place, in one position. If they are here, within 10 minutes, they will run around everywhere. With the brain liquid, it helps for coordination for children. And we also have the active memory for adults from the age of 40 and above. The Neuropsychiatric Hospital at Yaba and their annex at Oshodi, they are actually using this for children that have Down syndrome, and those that also have Parkinson's disease also use it. Then for we that are still okay, we use it just to boost our memory. Because for every adult, there is always a decline of 5% in memory every 10 years. That's why at a point to come in your life where your mama will begin to say, oh, are you Joseph? Oh, my grandson. But when you are using this regularly, you will not get to that point of asking, are you Joseph? Are you my grandson? So thank you for listening, and have a wonderful day.
I was somewhere to see one old man, 82-year-old man, and they said he lost his memory, and at the time when I got there, so, and I asked him, Baba, who is in your front? And he replied, she be Dr. Nologbewa. They went to bring doctor. Me ni ba. I said, Baba, nothing is wrong with you. And eventually, the product that she presented, one of them, I will not mention, was used for 2 months, and there was a reversal. So it's really true. If you get to your kitchen and you forget what you went to do there, please take it. On this note, I want to encourage us, if you have not taken your head shot, is it head shot or full shot? If you have not taken any, please, by the side, the photographers are waiting for you. I think we can quickly do that while we join our hands together as we welcome Zolon Healthcare, a member of the EMZO group, as they take us on the vaccine. You are not alone. Let's clap our hands together for Uche Kingsley Akubweze, the sales manager of vaccines. They've not clapped. Let's clap and welcome him. Yeah, come. Now you can come. Do Uche, vaccines, do they work? They do. Okay, come.
So if they don't work, I should go back. That's actually a very positive note to start with. So if vaccine works, so I am rest assured I should be standing here to speak to everybody. Okay, I will stand on all existing protocols. There was something that Chairman said before I came, before the lady that was actually presenting, Joyce, if I'm not mistaken, that's her name. And as much as possible, he wants it to be a bit interactive, not a normal presentation. And I understand because, one, I'm speaking to pharmacists. They are well-read, they are well-studied. So, building a context on the topic I actually want to present, if I build the context properly, there won't probably be any need for the slides. Because you already know what I'm coming to speak about. my most important thing to me is participation. So I want to find out who have not been with us in this course, in this mission, in this ministry, for those of us that are Christians, and who have been with us in this course, in this agenda, to actually eradicate hepatitis B. I came a bit early, being in context, and we had various discussions going on. One of the discussions was on airline. I think I had it with two pharmacists here, and we're talking about the cost of airline. I'm going somewhere with this story. And then the other was with somebody else that was talking about kidney. The problem, someone had a kidney problem, had issues, and they need to donate. And it was actually a very interesting discussion. So, because it's health related, so let me ask a question generally. How many people here would, if a case comes up, they'll be willing to donate a kidney to save somebody's life? Show of hands, please. Only one? Two? So, okay, I'm seeing those that are actually good-hearted and those that are a bit selfish. Let's just presume you are okay. Okay, if everybody is okay, 100% healthy, how many will donate? Okay, let's presume you are healthy. Let's presume you are healthy. The two kidneys, for now, yes. Now that you are healthy, how many will donate? Okay, we're not making it complex. I'm not presuming age. I'm not presuming anything. I'm presuming you are very healthy. How many will donate? At least one kidney. You have two now, so you can donate one. So 1, 2, 3, 4. The remaining will not. Okay, I should donate. I should put a context to it. Okay, donate to a loved one. You're very selfish, sir. Okay, so you donate to a loved one. So now we have 5 people. Okay, 6, 7. Okay, 9 now. Okay, we have more hands because it's a loved one. Okay. Okay, I should qualify it. Okay, beautiful. I think we've answered that. So out of the 9 people, because I'm presuming the many people that refuse to raise their hands are selfish, how many would donate their liver to a loved one? I did not ask what will happen to the person. I asked who will donate. You will donate, eh? No, it's love now. We have 1. Yeah. See, the question, I'm not asking what will happen to you. We know what will happen to you. We said this to a loved one. So how many? Eh? You can will it. No, you are alive. The person is about to. Okay, sorry, there's a question coming up now, please. This one house, there's a question coming up. Is it the whole liver or part of the liver? Okay, let's start with the premise is the whole liver. How many?
That simply means you want to end one life to start a new life. Even a loved one. That's why I said there is a shared, if you can share it, I will share it.
Okay. Okay. Somebody is asking now, me that is asking the question, I should also raise my hand whether I will do it or not. I'm the one asking the question, so I'm immune. Okay. Yeah? Okay, sir.
I will say that is a murder case. The person that is about going can go in peace. But you want to kill, what is the probability that that person will survive 100%? So that is a murder case.
Okay. Okay. Then I think the next question will be actually to a pharmacist that is actually partnering with us in this program. She's heading heard the program, the education program that we do with PSN.
The MZO normally sponsors vaccination training with ACPN Foundation, and they've been doing really well. So I'd like to thank them.
I actually have a question. Okay, I actually have a question. How many of the pharmacists here are participated in the program? Even if we're not sponsoring, but those that have participated to actually push away this hepatitis B. How many?
I think a lot of ACPM members here have done that training. For the people here I'm seeing, it's only those in the hospital that have not done that training.
Okay.
So
it's not everybody?
Not everybody.
Okay.
But it's mostly for ACPM members.
Okay. So actually, at least it's a pass mark. We have a good percentage of people that have participated in the program. And I'm going somewhere with all this interaction. Because I looked at the slide when the guy was uploading it in the system. And let me close to, okay. I looked at the slide that I wanted to present. And it dawned on me, most of the people here can even write a better slide than this. So it is not slide work that I came to do. I actually came to solicit for participation into what we're doing. And then even if you have gone through the training, I've noticed that a couple of people that have gone through the training are not doing anything with it. So we wasted our money. You wasted your own money. You wasted your own time. I wasted coming here, entering a portal, and then people pulling the car out, and then. So I don't want it to be a waste of our time. I know it costs a lot now to come out. Sometimes when you look at outside your window, you want to give an excuse that I don't want to come out because you look at the expense on a weekly basis. Averagely, I don't know, from where I'm coming from, it's 30,000 every week. It's not sustainable if I'm not doing something reasonable with my time. So let's go to the slide. So what is hepatitis? It means inflammation of the liver. It means viral hepatitis means there's a specific virus that is causing your liver to inflame, swell, or become larger than normal. We all know this. This is what a healthy liver looks like. This is what an unhealthy liver looks like. And the job even if I don't do anything, probably you forget the slides. The most important thing to me is you help participate in making sure it does not progress from this. Does not progress from this to this. Okay. So it does not progress from this to an unhealthy liver. So this is what a closer look of an inflamed liver looks like. The wall of scar tissue begins to form. Healthy liver cells become trapped by a wall of scar tissues. This is what we're avoiding. Everybody here has studied it. I believe the interaction that we started with should put it in context and help us remember this is what we're fighting for. So there are 5 main strains of hepatitis. There's the A, B, C, D, and E. Interesting enough, B and C and D are the ones that cause chronic infections. A and E cause a mild infection. But there are vaccines for A and B. So WHO estimates that there are 1.4 million cases, or deaths rather, yearly because of hepatitis B. Hepatitis. And B and C represent 90%. If you put that in context and you calculate the number, that's about 1.26 million. So hepatitis B itself should be the result of 1 million deaths averagely in a year. The person might not be near you, the person might be far, but sometimes it could be near you. B and C are responsible for 90. Okay, I've read that. 290 million people are living with viral hepatitis unaware. That's an issue. They don't know their status, going about their daily lives, not knowing they're infected. I've had, because I started this job as a rep, progressed to a manager, and I've had cases whereby it's when they are getting married, and God bless those institutions that actually push for when you're getting married, go and do proper screening. And they found out, I had a case where a woman found out that the man she wanted to get married to was positive. Beauty enough, God bless, thank God, there was no intercourse before the marriage. And now they are 2 months to the wedding, and they're finding out that the guy is positive. Usually problematic when it's the woman that is positive. But this time it was the guy that was positive. And we still running around trying to solve the problem so before they get married. The other thought was, should we shift the date? And the man said no. Insistively, no. Let's do what we can do, but nobody's shifting the date of the wedding. So one person dies every 30 seconds. I don't know how long I've been speaking. Probably I've been speaking for 10, if I presume 10 minutes. Then probably, how many people have died? 20 people have died during the course of my discussion. The burden of the hepatitis constitutes a public threat, health threat, in many areas of the world. So in 2016, World Health Assembly approved the global strategy, and the aim was simple. 2030, no more hepatitis as a public health issue. And so we are going around the nation pushing for participation. These are the most important people to participate in this program. Why? Because the food traffic in the pharmacy, in your pharmacy outlets, has increased, especially in this economic situation. We know that most patients, when they think about it, the first line of treating an infection in the country is your mother's dining table. There's usually a set of drugs she keeps at one side. The next stage, if that passes, is the pharmacy. And it stays longer in that position before going to the hospital. And the reason why is disposable income has reduced. People are not willing to spend unless it's a life and death case. So if the interaction is happening more at the pharmacy center with the pharmacist, then they are in the best position to actually push for vaccination, push for awareness, push for education, then remove misinformation from the patients. So in context, hepatitis is 50 to 100 times much more infectious than HIV. I think everybody understands this. But putting in context, let me use with the first person that actually said I should specify what I mean by who is donating. Who am I donating to? So he probably decides to go to barb his hair now. And he gets to the salon. And God forbid, somebody barbed there with a clipper. And because he had an appointment that was going to give him billions of naira. And he was not ready to wait. And he was not ready to go back to go and get his own clipper. Eh? You said no. How do we know you're not rush? You go and get your own clipper. Okay. Okay, but okay. So fine. In case using somebody else that will not will not want to wait. And someone has used the clipper before. The clipper was even kept for some time, for 2 weeks. 2 different scenarios. HIV, the virus will be dead. Hepatitis B, even if you add an extra week, most likely it's still alive on the clipper because there was blood stain on that clipper. And we do not take this in context when we have male patients or males coming to the pharmacist to actually explain to them, have you been screened? Have you been vaccinated? Because the awareness for the kids is doing very well. But for the average adults, they are not aware. Less more that they've actually even gotten vaccinated. So accounts for up to 80% of the cases in primary hepatocellular carcinoma, It's also second in importance only to tobacco among cancer-causing agents. Humans are the only host of the virus. Okay. So we have two types of transmission. We have the vertical and the horizontal. So vertical represents 1 to 5%, as mother to child. The horizontal accounts for the remaining, plus unprotected sex, plus close body contact, plus sharing of toothbrush. Interesting enough, why I put that toothbrush was, a couple of years back, I was with a nurse in a hospital, and we were just discussing about something else. And a lady, you could see from her appearance, she was very comfortable. So she had a new housemaid. And she said, I was there, so they didn't tell me to excuse, so I sat down. And she said she wants to screen her for everything on the list. And the nurse looked at her, said, pregnancy test is in this list, though. This girl is no more than 12 years old. He said, everything. Are you the one paying? I now looked at the lady, looked at the nurse looked at me. And when the nurse agreed, okay, you're the one paying, I went to go and get the necessary requirement to start the process. And I asked the woman, please, out of curiosity, don't be offended, though. Why are you insisting on everything? So, that she heard a story where housemaid was staying with kids, found out that later that the kids were hepatitis positive, or HIV positive, rather, and they screened parents, they were negative. They screened kids, they were positive. Okay, so how did they get it? Did they get it from school? They went to investigate, nothing. Okay, somebody just said, okay, what about this housemaid? Said, no, they don't do anything that would. He said, no, let's just try. He checked and she was positive. What was the problem? They didn't buy her a toothbrush, so she was using the children's toothbrush. And that same situation can happen for hepatitis. I'm seeing mommy's face squeezed there. So after the squeezing of the face, please participate in the awareness. Thank you. Take action. That is the main thing from here. So this slide is out. Okay. So 194 member states of WHO committed to eliminating viral hepatitis as a public health threat by 2030. And the first and most important to them was immunizing against hepatitis B. Second is prevention of mother-to-child transmission. Blood and injection safety, prevention of transmission of hepatitis B and C among persons who inject drugs. And we have that in our communities now because of the way the economy is. And testing and treating. Sorry, let me even go back. And interesting enough, all this can happen at your outlet. All this can happen, or all this can start as a process in front of you as a pharmacist, even if you don't have an outlet. So people living with hepatitis unaware can't wait to be tested. People living with hepatitis can't wait for life-saving treatment. Expectant mothers can't wait for hepatitis screening and testing. Newborn babies can't wait for their first doses. Community organizers can't wait for greater investment. And investment is knowledge first, time, and resources. And the first two is available to everybody before we start talking about the third one. And for the third one, as a company, EMZO, we participate in that to make sure that it's, as much as possible, the burden of expense is reduced for the community. One of the ways we do that is the free screening. We provide the kits. We also provide the transportation of the vaccine at no cost to your outlets. We also provide the awareness material at no cost to you, both digital and physical. I can skip this. So one of the roles of the pharmacist in eliminating viral hepatitis, demand. Most important thing to us, number one, is awareness. Next is knowledge. The value speaks of Someone said something interesting to me a couple of years back. He said this, if you're teaching salespeople how to present a product and they are finding it difficult, and they found it difficult for a very long time, you know it will take time to do the process. The quickest way for them to grasp it is let them have testimonials. Let them have seen results from other people. That's when they see the value in it. And then they will not teach it with intensity. If you understand the importance of this, you will teach it with intensity. Okay, so service. One of the things we're looking at is, or one of the things that we do, is actually the vaccine supply. We also help with the transportation. We also help with the storage. And then we also demand that for the basic storage in your outlets, we can support. We teach cold chain management to those that want to participate. And that's also done in the general training that PSN and ECPN does. And also help with the logistics. I don't think there's anybody here that will need ice packs to move it from place to place that will not be provided for you by us. Then we also want a participation. As much as possible. When you move from place to place, remove the burden of transportation from the parents, from the people. I know the good thing with the pharmaceutical the pharmacist outlets are they are in the community. So the burden of going from far distance and short distance is reduced. And that is actually what helps in the program, in participation of the program. Then, most importantly, misinformation has been happening around. I know COVID came with its own issues. And when it came with its own issues, one of the issues were misinformation. People now believe that maybe they want to use vaccine to kill them. They want to use vaccine to reduce the general population. They want to use vaccine to stop men from being reproductive. Okay, I think that's the reason why the man that introduced me actually asked, does vaccine work? And so, it does work. And so please help us in removing those misinformations. These are vaccines that have been available for more than 30 years. So trials and errors, clinical trials have been done, research has been done, even as the vaccine has been used in the general population. When I started as a rep, usually what they were telling us was every 10 years you vaccinate. Now the general information is every 30 years you revaccinate. Probably after 30 years, we'll probably pushing to 40 or 50. But as science evolves, we get much more information. Oh, sorry. So, role of the pharmacist in eliminating viral hepatitis. I just want to emphasize it again. Increase awareness in the community level, in the association, in religious grounds, that's churches, your mosques, even in the peer groups, the parochial meetings that we have in our communities. Then our own promise to you is this. MZO is ready to work with the pharmacist. If we've not proven it before, we're ready to prove it again. And we're ready to provide the screening materials available for free. But we just want participation. We want active participation. The screening materials will be provided. And the only question you usually ask is, how many people are you expecting for the screening, for the vaccination? Because there's no point in screening someone and he goes back to his lifestyle. Because if your screen is negative today, next day I don't know who you will go and meet or who will go and misbehave with and get infected. Thank you. So any questions? Okay.
Thank you very much for your presentation. I'm from Shifugunlade Olaitwani. We have started this program in our facility. We were doing screen, even, you know Ogo. Yes. Ogo was the one with us there. But people were coming in our vicinity. But something happened along the line. Some of the pharmacists around, they said, we went to Ministry of Health that pharmacists are not permitted to do screening in our facility. That was how we stopped. Because they came and they spoke with us that we should not do it again. But our community, they were really coming at that time. And people that, no.
I get your question. Okay. I'll answer one part, and then I'll also give the program coordinator a part to answer. One part is, I know generally they said pharmacists are not supposed to vaccinate or are they out there? But it's changing, it's changing. It's changing. And I know that the association, federally, is actually pushing for a policy. And I know there was a time that I actually saw the paperwork for it. They were pushing for a policy to allow pharmacists to actually vaccinate. The first time I actually did a training extensively, there was actually a professor from US, and it was, I forgot the name of the company, that was in 2011. And he was a pharmacist. And he screened and vaccinated us. And he taught in their outfits in US, they actually screen and vaccinate. Because how many people want to, okay, in the COVID era, will you want to go to the hospital? It's stupidity to me. And then part of the things that we also do is, why the training is also going on is, they actually give a certificate for training, and part of the requirement, part of the training is actually how to vaccinate. So, do you want to say something about that?
At the last panel session that was organized, that was some weeks back, these questions were asked to the ACPN National Chairman, and the immediate past secretary is here. I don't know, I think he'll be in a better position to explain. But from what he said...
Okay. Good morning, House. Well, I want to say something on this issue of vaccination. Just like what he said, the policy is bound to change. We are working at it at the national level, and I know we are going to succeed. But there's another thing that happened in Ogun State last week. A pharmacist went to local government or the ministry there and asked, I want to register my center as a vaccination center. And they granted him or her. You know, and they asked him, the only question they asked him, who is going to be vaccinating? And he said he will employ the CHU. All those people that go around and all that, go to the churches and all that, they train them. That the people doing the vaccination. I'll be true or false. And they granted her the position, and they registered her, they give her a certificate, and he started vaccinating. So, and most of us, I know in Lagos is a peculiar place. You can go to your local government and say you want to register your place as a vaccination center. And they ask, do whatever you want to do there. They can grant you that place, grant you the process. They ask you some or two questions, what and what do you want to do? Who is going to be vaccinated? Say true and all that. And they grant you the place, you pay them, they give you certificate, you begin to vaccinate. Why at the national level? They are still working at that level because we are vaccinating COVID now. They have flagged all COVID in all community pharmacy nationwide. Is it not true? Other little immunizations are coming. That is what we are working. And I believe with time we are going to achieve that. And if you do, you can do, by the time you ask for that and they granted, you can do adult vaccination and all that, but not other routine immunization like children and all that. But with time, we are going to achieve all this. But let us just think outside the box by going to local, initiate, I want to register. In short, by next week, I'll go to local government at Ajeromina. Tell them I want to register. If it's going to take me, even if I want to bribe them, I'll bribe them and make sure that I register my state at the center.
Sorry, please, the last 10 seconds there, we'll move it. Okay. Let me just say something before I give you the mic, man. But wait, sorry, can we get one house? Sorry. Can we get one house? This one house. Okay, I actually want to say something about this vaccination and the centers. There's the process you talked about, and you could actually do 1 day off. That is what we started with. I was actually looking out for one of the pharmacies that we actually started with. We kicked this thing off with her 2016 October. That's Lopez Pharmacy. And we did it 1 day off, weekends. And what she does is very simple. Her outlet, she already has her working customers. And she has good relationship with them. The flyers are on the table. The banner is outside. A small banner is outside. And most times people don't look at the banner. Interesting enough. So they come in, and as they are asking for this or asking for that, or sometimes just supplements. She's not saying, hey, have you been vaccinated? She looks at it and explains. And some of them say, okay, I'm interested. So how do you go about it? And she asks for a commitment. If the I don't want to call the price, but if the price, let me just say, if the price was 3,000 or 4,000 in outlet, she'll tell you it's 4,000, but make a commitment. Some of those men are comfortable enough to pay for the whole family. They'll pay you full sum. Some are comfortable enough to pay 25%. She asks a minimum requirement. Some are ready to pay 2,000. She has already gotten the cost of the vaccine. What she was pushing then was the cost of the vaccine coming to our outlet. So if you decide not to come that day, we can push you to another date. Then, because we were starting the process, we were just looking at, starting this structure, this idea. We're not going to burden her with storing at our outlet. So the day of the vaccination, in the morning, someone brings the vaccine to her. She already has employed a nurse. She already has a list of a certain number of people that have put down something for payment, put down something for commitment. So from that number, she can calculate her cost for nurse. So you have the nurse vaccinate, or the person that will vaccinate that day. And she will know she's not running at a loss for that day. Worst case scenario, she breaks even, she has created awareness. And the beauty of this thing is this. If I'm doing it and another person is not doing it, there's a distinction in the community. There's a very clear distinction in the community. So somebody can actually pass and say, that pharmacist, which one? That one where they took injection for hepatitis B. You've distinct yourself. You've separated yourself from the pack. So that was the low-cost method. Before we now started looking at other ways to actually help the pharmacist store the vaccine in the outlet. Ma, do you still have a question to ask? You still have a question? Okay.
I'm just wondering, if one is a certified vaccinator, do you still need to employ the CHU or nurses, except maybe you have many people to vaccinate and you need them to help you? Can't you do it on your own?
You don't need the people. You don't need. No, but see, the reason why I think that question was asked was when he was doing it, and that was 2017, if I'm not mistaken. We've not started. The training had not started. It had not started then. Huh? Now that it has started, you don't need. I think the only time you will need to actually be effective is having an experience, and is when the people are much. I like the person I was talking about. When we started, averagely there were just 25, 30 people. Averagely there were 25, 30 people. I do not determine a markup. She determines a markup after the vaccine is brought to our outlet, and she determines how the information will be relayed and how many times she wants to do it. Okay, so you want.
Sorry, I think one of the logical reasons why they want another healthcare professional to be around when you are giving injections is if something goes wrong, and sometimes things go wrong. You alone may not be able to handle it, even if it's within your purview to be able to do it. While you are keeping an eye, you want to run there, you want to do that, there must be somebody, give me this one, give me that one, do this, bring me the heart, the BP is down, give me adrenaline. So somebody will have to be around, not somebody that is not a healthcare professional. I think that's one of the reasons. But I don't know, but then at least they are also healthcare workers.
Thank you. Thank you very much for that contribution, sir. Okay, you have a question? Okay, hold on.
Okay, my question has to do with two patients, a male and a female. The male was beaten by the female. So I was wondering if the virus survives in the saliva, or who should be the one to go and check. I don't know.
I think both the person actually beat should go and screen. Yes, because we need to screen to determine whether it's actually hepatitis B. You can't just presume that because somebody beat somebody, the person gets an infection. So we need to actually screen. Yes, it can be in this, yes, especially if the person is actually chronic. Yes. Any other question, please? do I have any other question, contribution? Okay, so I'll take my bow. Thank you.
Please, thank you very much. You can, I know you are, most of us are elders, and it is important that you stretch your legs so that your blood flow will not be impeded. You know, Professor Ku just taught us about things on CVA and the rest. So please, rise up on your feet, go for tea break, go for photo shoots, head shots, leg shot, body shot. They are there waiting for you. And we'll come back in 10 minutes. Thank you.
Hello, let's come back in. Please. Let's come back in, please. Yeah, please, who is this?
Please, let's come in. I think we have had our headshot and our tea break. Let's come in, let's come in, let's come in. Please come in, love, come in, come in. There is no tea, come and take another one. Please, let's come in. Headshot. Oh yeah, let's come in. And don't forget that tomorrow is the opening ceremony. Please, let's come in. Please, don't come here tomorrow. Don't come here tomorrow. Tomorrow is Sheraton, you know. Don't come here and tell us that you missed your way. It's Sheraton, you know. Tomorrow. I have gifts for us, and I will distribute to only those who are seated. Those who are seated. I have gifts for only those who are seated. I have gifts for those. Where's my pocket, sir? I have gifts for those who are seated. Let's join our hands together as we welcome pharmacist Adekola Wojuola, who is going to give us a brief talk on vaccines. So yeah, please clap for him. Oh. And if you are standing, sit. Secretary, please pass the attendance sheet to only those who are seated. Thank you very much.
Thank you, sir. Good afternoon, distinguished colleagues. Elders in the house, I salute everyone. As men of honor, we join hands. My name is Adekola Wojuola, pharmacist. And I want to believe that everybody in this room has an interest in pharmacy-based vaccination. The study shows that 36 countries across the world have in-pharmacy vaccination. Nigeria is getting close to officializing that, but I must say that we have come a long way. My background is I was a group product manager for GSK vaccines from 2016 to 2018. So the last project I took up was to look into pharmacy vaccination. And what we found out that there was a time that GSK actually gave 86 pharmacies across Nigeria ice-lined fridges to start immunization. I don't know whether anybody here benefited from it, but in just 1 year, it was only 10% of those that received the fridges that actually started the vaccination or continued. So what exactly was the problem? Because the vaccines were available, the fridges were available. Guess one thing that was missing? The one thing that was missing was the interest of Nigerians in prevention. We all know it. We don't have a culture of preventing things. We wait for our cars to start giving problems, usually, before we see the mechanic. if I ask now that how many of us have been doing our tests, I mean overall tests, what do we call that now? What do we call it? Comprehensive. Okay, you know that the moment you click 40, you're supposed to be doing it every 3 years. Every woman is supposed to be doing a pap smear every 3 years. But if I ask now that how many women have done their pap smear to find out whether they have human papilloma virus or not, I don't know how many I will get. If I ask now that we as healthcare professionals, how many of us have taken our hepatitis B vaccines, hepatitis A vaccines, and so on and so forth, I don't know how many people. So the problem is not about the fridges or the vaccines or the trainings. The problem usually is in the people we relate with, starting from we ourselves, whether or not we really believe in prevention. And so we have floated a company called Preventive Health Nigeria, and what we do is to interact both with healthcare professionals and with the general public to raise awareness on the value of vaccines. And we hope that by doing that, we can actually get more people to make vaccination decisions and make their way to the closest healthcare professionals that are the closest to the people. Who are those? Pharmacists are the closest. We are the closest to the community. So we hope that by doing that, we will be able to raise the bar of vaccination. And I know the frustration involved. I've heard some of the comments. I know many have tried to do one thing or the other. And I know the frustrations involved, but we have your back. We are building a global network as well as a national and local network. So come 25th of this month, that is the World Pharmacist Day, we are having an event which will bring pharmacists together to discuss about what next to do. I know that many of us have gotten certificates upon certificates, trainings upon trainings. But the real thing is, why are the vaccinations not really happening? I don't think it's legislation. And I've heard some comments about, are we supposed to do it or not? That might not be the issue. There are some key issues we need to address. So I will officially invite you. I'm going to, for everyone that's here today, you're going to get an invite for that meeting. Please attend. We've been able to get some key stakeholders who have actually practiced vaccination in their pharmacies. They will be giving best practice, and it will be a clinic that's open to anyone to ask questions on how best to start. Because the issue is, how do I start? And once you start learning along the way. We also carry out consulting services for those that, I want to do it, but how do I go about it? What's the strategy plan? We do that also. So thank you very much. I think we're on the right course. We are doing well for our level. It will happen as we begin to mount more pressure, as it were, on the legislative part and also on the community part, where we let people know that pharmacists are very, very crucial in strengthening the healthcare system in any country, just like we've done in other European and American countries. So thank you very much. We'll make sure that we circulate the invite so that you can join. It's an online meeting, and it's free to attend. Thank you very much. I'm very grateful. Thank you, sir.
Thank you very much for those nuggets. We look forward to the invites. Now, quickly, let's invite the speaker for the next masterclass session, and that's Pfizer. Pharmacist Louis Ojukwu will be talking on the role of pharmacists in adult vaccination. The role of pharmacists in adult vaccination. Please, a round of applause for him. He represents Pfizer Specialties. Thank you.
Good afternoon, distinguished pharmacists, my senior colleagues in the building. My name is Pharmacist Ojukwu Louis, and I work with Pfizer. I would like to stand on the already existing protocol, and I would also like to appreciate the opportunity being given to Pfizer from the leadership of the Pharmaceutical Society of Nigeria. Without them, this event would not be possible, so we appreciate them very, very much. Then, I would still like to appreciate the leadership of the society, because the leadership of the society has been at the forefront of adult vaccination, or vaccination in general. And before now, we know that vaccination has not really been a thing in the community pharmacy, not even just community pharmacy or the pharmacy setting. But right now, pharmacists, community pharmacists has really been at the forefront of the vaccination exercise. Now, this society also has helped equip pharmacists at the community level, at the rural level, at the hospital level, with the necessary knowledge, resources, and equipment to further advance vaccination exercises to the patients. Like one of the previous speakers said, the pharmacy is usually the touch point for patients now in the country due to the economic challenges. Before a patient may have to go to the hospital, it's either going to be a life or death condition. Everybody is trooping into the pharmacy. So the pharmacy is usually or is currently at the forefront of the vaccination exercise. Now, these vaccines or these immunizations we have been talking about, there has really been a misconception before now that vaccines are basically for children. Anytime you hear the word vaccines, they'll tell you, my child has vaccinated, me, I don't need to vaccinate. If I would ask this house, how many people have had vaccines as adults? Because you know there are several vaccines that are very, very eligible for adults. So you have had your vaccine. Which of the adult vaccines have you had? Okay, so everybody has had COVID vaccine. Okay, hepatitis, COVID. But these are not the only vaccines we have for adults. Okay, I heard someone say yellow fever. Okay, you've had yellow fever. So we have yellow fever, hepatitis, COVID. I heard someone say meningitis. So what about you? Have you had any adult vaccination? Yes. You're free of. That's the problem. The essence of vaccination is to prevent the occurrence of certain disease condition. The essence of vaccination is to prevent certain disease condition. We saw with COVID, with Pfizer COVID vaccine. You don't have to come down with the disease condition first before you get vaccinated. The idea is prophylaxis, to prevent it from even occurring. Mama, if I'm to ask you, which other adult vaccine, yes, both of you, which other adult vaccine have you had? COVID, meningitis, hepatitis. Have you had pneumococcal vaccine? Pneumococcal. Ma, what about you? What are the adult vaccines you have had? COVID, hepatitis, yellow fever. That's it. No pneumococcal vaccine. Okay. Well, that's why we're here today. So we found out that in general, the uptake for vaccines for adults has been really, really, really low in our climate here. You go to the Western climes, you see adults taking regular vaccines for adults. You have the likes of, like she said, COVID vaccine, the flu vaccine, pneumococcal vaccine, for example. In the US currently, an adult clocked age 60 and above is very, very mandatory for them to take the pneumococcal vaccine. Same thing in Canada as well. You clock age 60, it's very mandatory for you to take these vaccines. Pardon? So, how do we as pharmacists play a role in these vaccines or in this vaccination exercise? Now, if I ask, for those of us in the community practice, is there ever a day in your practice that you don't get to see a patient with maybe hypertension, cardiovascular conditions, lung conditions, or sickle cell patients? Is there ever a day in your practice you don't see these classes of individuals? Or you just open the pharmacy every day and you see people with just headaches? Is there ever a day you don't get to see somebody with hypertension? You don't get to see somebody with diabetes? You don't get to see somebody with asthma? You must see at least one every day. So you see how important these classes of individuals are to your vaccination exercise. Oftentimes we get to hear pharmacists say they don't know this person is supposed to take this vaccine. This person doesn't know he's supposed to take this or that vaccine. Now, these classes of individuals are your patients. So the importance of vaccination for your patients
is as important as your pharmacy license, because I mean, the objective of the day is to make money and improve your patient's quality of life. And to that effect, one of the adult vaccinations, or majorly the adult vaccination Pfizer is promoting, is the Prevnar 13 vaccine and the Nymerix vaccine. The Prevnar 13 vaccine prevents against the pneumococcal disease. Now, this is going to be our outline for today's conversation, the background information on pneumococcal disease. And the very first speaker, Prof, he made mention about pneumonia and how fatal pneumonia can be. Now, with this vaccine, you can even prevent such fatality from occurring in your patients. We'll look at the need to vaccinate your patients, the licensed vaccines available commercially globally, and effectiveness of these vaccines, and recommendation or guidelines for these vaccines we're talking about. Now, from basic pathology, we know that pneumococcal disease is of two classes: the invasive disease, or the invasive pneumococcal disease, and the non-invasive. Just to put it in plain perspective, for the invasive, we are looking at the Streptococcus pneumoniae crossing into the sterile part of the body. And where do we classify as the sterile part of the body? You're looking at the blood, the cerebrospinal fluid, the SBF, basically anywhere that is very sterile, that is not supposed to have unwanted material or wanted substance. Then you're looking at the non-invasive forms, the pneumonia you see in your pharmacy practice every day, the acute otitis media you see every day in your practice, the sinusitis. Yes, I believe we see sinusitis often and on in practice. And this sinusitis can actually be prevented via vaccination, because it's what? Caused by this same Streptococcus pneumonia. Now, there is no disease condition you want to mention its body or its global body or its epidemiological body in this world currently that you won't see in Africa. Thank you very much. You're looking at the highest burden is in Africa. You're looking at fatality rates. You're talking about Africa. I heard somebody mention COVID. It was only COVID that we didn't see such trajectory. But aside COVID, I don't know. Any other disease condition you want to look at, you're looking at pneumonia, you're looking at hepatitis B, you're looking at breast cancer, you're looking at prostate cancer, whatever the condition would be. Why? Because we are still a developing country. Our country, we are still far, far behind. If we cannot eliminate these disease conditions, we can prevent them from progressing. It's that simple. If you cannot eliminate, at least halt its progression. Now, Nigeria accounts for about 5% of the global death burden of this said pneumococcal, just behind China and India. And we know that why Nigeria is third is because India and China has a greater population than ourselves. If Nigeria had a greater population than these countries, we will most likely be number one or number two, most likely. Now, what are the risk factors of this pneumococcal disease we are talking about? What would predispose patient A, patient B, patient C from this disease condition? One of the risk factors is age. Daddy was saying he's fine. Age already is putting him at a risk of the disease condition, whether you like it or not. The fact that you have aged. We'll get to that, sir. The fact that you're aging, there is nothing you can do about it. The fact that you are aging or you're within a certain age range, you're already at risk of this disease condition. Now, underlying medical condition. From practice, we understand that patient A is hypertensive, patient B is not hypertensive. From practice, we understand these two patients may look very healthy, but they are not. Patient B is hypertensive, is diabetic, and is asthmatic. We understand the way you handle this patient is going to be very different from the way you handle the other patients. So underlying conditions can have a role to play in the management of certain medical conditions in practice. Then another risk factor you're looking at is environment. With the likes of COVID, we saw that cover your face, don't stay clustered in a particular environment. Living environments has always been a risk factor for certain disease conditions, of which pneumococcal disease is one of them. Now, mortality in invasive pneumococcal disease is high regardless of age.
Now, from same pathology, we understand that immunosenescence sets in when we age. Daddy, immunosenescence sets in when we age. What does that simply mean? The functionality of your immune system drops as you age. That is standard in life. That is why you will see Manchester United will pay £100 million for a player of 20 years, but they will never pay that money for a player of 30 years or 35 years. Why? Because they believe the value of the older patient drops with time. So that's just it basically. As you age, the functionality of your body system drops. So it is very important that as you are aging, the functionality of your immune system is dropping. You are protecting it in the very best way you can. Lifestyle modification, prevention of the disease, if it's actually a preventable disease, and the likes. Now, we can see that the mortality rates for pneumococcal disease can go as high as 20%. Highest mortality is in young infants. Why still? Because the immune system has not yet developed as it should. That is why you tend to see them getting several kinds of vaccines. Pneumococcal vaccine, meningococcal vaccine, to protect them. Why? Because their immune system is not as strong as we would expect it to be. Then for older adults, immunosenescence results to the dropping in their immune function. Then case fatality can be as high as 60% in adults. That is a very huge number. If there are 100 patients here, the chances of fatality in that class of patients is about 60 out of 100. So that's a huge number. So we may think it's not as deadly as we believe, but it's actually that deadly. Now, in cases where, patient has come down with this disease condition, and you say, we'll treat. After treating, we saw with COVID, people got COVID, recovered, but they recovered and had some problems. Same thing too with pneumococcal disease. You might say, yes, you will treat. You don't want to prevent first. I don't want to take vaccine. Remember that there are certain conditions, the likes of hearing loss. There's a hearing loss, motor abnormality, mental retardation, seizure, several other complications that we don't know of yet. Probability when that your patient has come down with it, we'll start finding out about that one. But that is not what we want for you and your patients. Now, this is just the burden of this pneumococcal disease we have been talking about. Look at, as the case is going up, for every case, mortality is going with it. The more pneumococcal disease is coming, the more death is associated with it. And this is not what we want in Pfizer. We are very much interested in bringing breakthrough that will halt this trajectory. This information you are seeing are human beings dying every day as a result of this disease condition. Now, for the other risk factors we made mention of, underlying disease conditions. Like I said, every day we see patients that are diabetic. Every day we see HIV patients, depending on where you work. Every day you see immunosuppressed patients. Every day you see smokers. Every day you see people that drink alcohol, both the chronic alcoholic patients. These are people you see every day. Or is there ever a day you don't see somebody that smokes in your practice, if I'm to ask? Is there ever a day you don't get to see a smoker or a diabetic patient or a patient with asthma? Is there ever a day you don't get to see this class of patients? Sorry? It's very rare not to see them, yes? Thank you very much. Now, oftentimes, or most of the time, we see these classes of patients every day in practice, be it in the community, be it in the hospital, be it in churches, be it in centers like this. If I'm to say, I'm sure there are some pharmacists here that are actually diabetic, hypertensive. So these people are not ghosts. These people are human beings like myself and yourself. So now, in cases where a patient is living with a particular underlying condition, that underlying condition has already put that patient one step at risk of contracting this pneumococcal disease we're talking about. Now, age
doesn't really come into play here now for this class of patients. There are patients that are 20 years, and there are patients that are actually 20 years that are diabetic. There are patients that are 35 years that are diabetic. There's an 18-year-old lad smoking. His father does not know, his mother does not know, but you as a pharmacist, you know, because you buy these things from the pharmacy. Now, in these classes of patients with certain underlying conditions from age 19 and above is already at a risk of this pneumococcal disease condition. So in this class of patients, you don't now wait till they're 64 or they're 60 before you start introducing the vaccine to them. You see that 35-year-old man that buys Novask every month. You see that 20-year-old lady that is on the obese side that buys Lipitor. That is your patient. Because the risk of pneumococcal disease in that particular patient is already higher than probably a lady that is 50 without any of these risk conditions. So it's very important. For patients with lung disease, we can see they are 5 to 17 times more likely to develop this disease condition. Then for the cardiovascular patient, your patient with stroke, previous history of stroke, previous history of congenital heart failure, hypertension, whatever the cardiovascular condition will be, they are 3 to 5 times more likely to develop IPD. Same thing with your diabetic patients as well. For immunocompromised patients that have, I heard Mr. Uche was talking about kidney transplants, if somebody could donate his kidney. Patients that have donated their kidney, or patients that are on immunosuppressants, the likelihood of them coming down with pneumococcal disease is as high as you can ever imagine. For those class of patients, before you even go in for the transplant, you have to take the vaccine. That one is standard. In case where you don't take it, the risk of coming down with this invasive pneumococcal disease is as high as you can imagine. Then for your smokers, alcoholics, the risk of developing this disease, again, is still very high. And these are human beings we see every day, not ghosts. Now, pneumonia is among the most frequent causes of hospitalization due to infection in diabetes. Now, this is diabetic case study right now, practical case study. This is the infographics. For a diabetic patient, we see them about 35% likely to come down with pneumonia. Then for, about 29% for pneumonia. Sepsis, 35%. Skin, urinary tract infection, as high as you can imagine. This 29% you might think is very negligible, but to the doctors it's not at all. This 29%, if we should transcribe that to the amount of patients that may most likely die from it, you will see that that's a very, very huge number. It's not working. Now, if I'm to reiterate, the risk of patients coming down with this pneumococcal disease, like I stated earlier, is age, increase in age, or patients living with certain underlying condition irrespective of age. Then living environments, patients that, not patients this time around, people going for Hajj, people going for Umrah in Saudi Arabia, and for the Christians, people that go to pilgrimage in Jerusalem and the likes. Then for our kids, for your kids, because I don't have a kid, for kids going to boarding school, you have about 30 or 40 kids in the hostel or in the dormitory. These are risk environments your kids can come down with these disease conditions. You're looking at universities, you're looking at camps, your kids go for NYSC camp. These are avenues by which they can get this pneumococcal disease. So it is very, very important. Your child is going for camp. It is very important to get this child vaccinated against, say, pneumococcal disease. If you look at, let's bring it back to our practice or to our normal day-to-day activity. You see people jabbing to the UK, jabbing to the US, jabbing to Canada. Is vaccination one of the requirements for this jabba? For the US, it is. For the UK, it is. For Canada, it is as well. These people know why this is a requirement, because they don't want you to come and upset the scale or distort the epidemiology or certain disease conditions in their country. So it is very important in environments that
we curtail this disease progression. Now, the next question is, why vaccinate? We have been talking about the disease burden, how it affects us in our society, how it affects us in Nigeria, how it affects us in practice. Why do you need to vaccinate? Yourself to start with, your family members, then your patients. Now, like I stated earlier, Streptococcus pneumoniae is a bacterial infection. And when you hear bacterial infection, to curtail bacterial infection, the need for an antibiotic has to come into play. Now, we know that the increase in abuse of antibiotic in Nigeria has skyrocketed off the roof, that we are experiencing resistance every day. You see a culture results. You are seeing virtually all the antibiotics used in culturing this bacteria is resistance. That is a major concern. And Pharmacy Society of Nigeria, I believe, are at the forefront of promoting antimicrobial stewardship. I'm very sure of that. Increase in antibacterial resistance has been a major problem even before now. If you prevent pneumonia from occurring in the very first place, there may really be no need to give an antibiotic in the pharmacy. Now, assuming a patient comes down with certain bacterial condition, he buys the antibiotic, gets better. Tomorrow, his sister or his husband or his wife is coughing or is coming down with certain symptoms that may seem similar with what he or she had. He will go to another pharmacy in your absence and buy it. And most likely, they are both not of the same disease condition, resulting to indiscriminate use of antibiotic that will still result to antimicrobial stewardship, antimicrobial resistance at the end of the day. So it's very important. If it's preventable via vaccination, why not just vaccinate and prevent the use of antibiotics? Vaccination can be the difference between life and death. This one is standard. We saw this with polio. We saw what polio did to the world. And how was polio eradicated? Vaccination. Even with COVID, we saw that the whole world was on standstill waiting for the vaccine to come. Everybody was waiting for these vaccines to come. So vaccination can actually be the difference between life and death. You think you are healthy, you don't know that it's just this vaccine that is remaining. If you don't take it, you are going to the other side. So it can actually be the difference between life and death. And oftentimes, I like telling pharmacists, we think we are pharmacists. Everybody is a patient. If you think because you're a pharmacist today, that tomorrow you will not be a patient, that's a huge lie. We saw that with, may God bless her soul, Dr. Verara in General Hospital. We saw that with her. I saw her that day she died, actually. We laughed, we just joked about life in general. Did she know she was going to be a patient that day that would not survive? She didn't know. So you think you're healthy today or at this moment. The next moment you might be a patient. And vaccine can actually be the difference that would save that your life or the life of that your patient. So let us not downplay the importance or the essence of vaccine or vaccination in our practice. Since the advent of pneumococcal disease, it has actually reduced mortality rates. Like I said, it can actually be the difference between life and death. With the introduction of pneumococcal vaccine, we saw the rate of mortality in vaccine in the pneumococcal disease drop significantly. We saw that with polio. We saw that with several other disease conditions as well. Vaccine-preventable diseases are expensive, if I have to be very honest. Right now, everything in the country is expensive. Antibiotic, expensive. Fuel, expensive. Cost of running a pharmacy, expensive. Lights, expensive. Can anybody mention anything that the price has not increased within the last 1 month here? Okay, let me reiterate my question. Can anybody mention any commodity that has not increased, that its price has not increased within the past 1 month? but you have to use a car or a plane to go to that place to pay the bride price, right?
you have to transport yourself to go to that place to pay the bride price. So, in one way or the other, you're still very much affected. Okay, bride price is not a commodity. Thank you very much. Thank you very, very much. Okay, it's a service. So, my question was, is there any commodity that its price has not gone up within the past 1 month, the past 30 days? I saw Swiffer said, we are sorry to announce our price has gone up. Please patronize us. Get the price at discount here. You better get it here because outside here it would be definitely expensive. So the price of the price of treating these disease conditions can be very expensive. Pneumonia, your patients come down with pneumonia, chronic pneumonia, and the patient has to be hospitalized. I heard Prof made mention of using ventilator or oxygen. You really do not have any idea how much it costs per hour for oxygen in public institutions or private institutions. Really expensive. Really, really expensive. A patient comes down with pneumonia. He's on admission. He's most likely going to be on IV antibiotic infusion. That's going to cost money. Now, oftentimes I like to make it clear that expense is not always about money. I mean, where would you like to sleep? At the comfort of your bed at home or at a hospital bed in Ibobi? The patient will be on the bed in Ibobi, but you taking care of the patient, you're not definitely going to be on the bed. You'll be on a chair. Or if the pharmacy is gracious enough, they will give you a carton. You'll sleep on the floor. I'm sure that's not what you want. I'm sure that's not what you want. If you ascribe that to expense, that's costing you your time, your peace, your state of mind. That's expense, if you ask me. It's an expense, but not a financial expense. So it's going to cost you a whole lot. Why not just prevent this wahala, sleeping on a carton, running to the lab to do tests, to do all of that? It's preventable. Why not just do it? It's that simple. Now, let's look at the US, for example. In 2010, it cost them about $36 billion to manage chronic obstructive pulmonary disease. That is a respiratory condition. And pneumonia is a respiratory condition. In 2013, the Health Institute funded COPD. I heard somebody coughing. I hope that's not pneumonia. It cost them about $101 million for COPD research. That's money that if you funnel into somewhere else, it can result to productivity. We saw the government remove subsidy money for fuel. We don't know where they funnel the money into. So in the US, prescription costs for pulmonary obstructive disease conditions, that is drugs that patient had to take, in 2018 is about 20 billion naira. Medication cost is rising every day. It's rising. So it's expensive. I'm sure no parents want their child to go and play carelessly and injure himself or contract one condition or the other. Because it's going to cost money. It's definitely going to cost money. And everybody wants to cut costs right now. Vaccine can help you cut that cost, if I have to be very honest. Now, to the topic or to the main discussion of the day, the vaccines. We have been talking about vaccine for pneumonia. There are virtually 2 types of vaccines available in the market for this pneumonia we have been talking about. You have the plain polysaccharide vaccine. That's called the PPSV23. Then you have the conjugate polysaccharide vaccine. That is the PCV13. Now, it is very important for us as pharmacists to understand the clear difference between these vaccines. I was with a pediatrician on the island about last month. He couldn't even tell the difference between the vaccine that is a plain polysaccharide and a conjugate vaccine. He couldn't tell. Will I fault him? No, I'm not going to do that. He probably didn't take immunology as a course in pharmacy school. But I'm sure there's no pharmacist that trained locally or internationally that didn't undergo or that didn't take immunology as a course in pharmacy school. I wouldn't fault the doctor, but we would fault a pharmacist that cannot tell these differences. Even if I don't, you will be fault. Yes, PCN will fault you. So it is very important to understand the clear difference between the plain polysaccharide pneumococcal vaccine and the conjugate vaccine. For the plain polysaccharide, yes, it activates the B cells. It will generate immunological response. But the response is not going to be long. It's going to be short. And will it generate a long-lasting memory for this particular disease condition? A plain polysaccharide wouldn't do that. It doesn't have maturity. It doesn't have affinity for the IgG antibody in the body. And this plain polysaccharide, we know that pneumonia is an airborne disease. Its effect on the nasopharyngeal tract, that is the nose, is really, really very minimal in its effect on the nose. It's really, really, really minimal. Yes, it elicits pharmacological response to the disease condition. Yes, nobody is saying it doesn't. It does. But there are limitations to it. Its response is not long-acting. Limitations with it are nasopharyngeal carriage, and its affinity to the IgG, which we know is the BB for antibodies. Now, comparing that with the conjugate polysaccharide vaccine, we see that it generates T-cell dependent immune response. And not also doing that, it induces immunological memory. That is, upon taking the PCV vaccine, that's the conjugate vaccine, come today, come next year, come 10 years from now, it will still remember. It will definitely remember. But compared to the plain polysaccharide, if you take it today, you would have to take it again next year. Because by 365 days, the response you're supposed to induce will drop. So you have to keep taking it yearly. If we are liking that to another vaccine, you look at the influenza vaccine that's available locally and internationally as well. You have to take your flu shots. How many times? Yearly. You take flu shots yearly. Why? Because it's a plain polysaccharide vaccine. It doesn't induce long-lasting immunological memory. But with the conjugate vaccine, you take it now and you're done. For life, you're done. It reduces nasopharyngeal carriage. And we know that with vaccines come herd immunity. You take it now, the carriage on your nose is reduced. The likelihood of transmitting it to the next patient still reduced as well. So you are protecting yourself and you're protecting your wife. You're protecting yourself, you're protecting your kid. You're protecting yourself, you're protecting your employee as well. For the kids, that is for the pediatric population, because of their immune system, it's usually advised to take a booster dose. But for adults, just a single shot is enough to induce the said immunological response we are talking about. So in general, between both vaccines, conjugate vaccine induces immunological memory, reduces nasopharyngeal carriage, and generates higher affinity for antibodies. That is the IgG antibody. Now, the topic of the discussion still is the conjugate vaccine. A while ago, Pfizer produced or manufactured the first conjugate vaccine known to man. That is the PCV7. As you can see there, the PCV7 ab initio protected against 7 strains of the pneumococcal serotypes I've been talking about. Over time, a PCV10 came into play. And this PCV10 protected against these 10 strains. But we know how bacteria works. As you are trying to combat this bacteria, the bacteria is also looking for another way to evade your actions. So over time, Pfizer kept innovating. From PCV7, we have PCV13, and currently there's also PCV20 as well. But importantly, PCV13 is the only PCV vaccine that contains serotype 3, 6A, and 19A. It is very important. We have this at the back of our head. Why is it important for us? Serotype 3 is an important serotype that is responsible for causing invasive pneumococcal disease that is associated with CAP. That is community-acquired pneumonia. That pneumonia you can get in the community, in your compound. Somebody is coughing again. That's what we are talking about. It's probably coughing out serotype 3. So you see how common it is. Serotype 3 is responsible for that. Why serotype 6A has been found to be the multi-resistant strain. That strain that this patient is coughing every day. He's coming to the pharmacy. You are giving him azithromycin but not Zithromax. Or you are giving him augmentin. You are giving him everything you have because of that cough. Today is coughing. Tomorrow is coughing. He probably has pneumonia. You don't know. Because serotype 6A is the multi-resistant strain. Now for the serotype 19A, it has become the leading cause of pneumococcal deaths. And this 19A, studies have also shown that it has been really, really multi-resistant to antibiotics. This is an antibiotic that we are propagating for stewardship, reducing incessant use of antibiotic. Patient comes today, you give him antibiotic A. The cough does not go. He comes tomorrow, you give him another one. You keep giving him antibiotic. You're not practicing antimicrobial stewardship because you are part of the problem. You are the one promoting the resistance that we have all been fighting about. But you can simply prevent this in your next patient or in the rest of your patient by just simply vaccinating. So it's very important. When you hear pneumococcal vaccine, don't just say, when you hear pneumococcal vaccine, don't just say, okay, there is plain polysaccharide, I take that one. Or there is another PCV10 that probably doesn't have this thing we are facing currently in Nigeria. Serotype 3, 6A, and 19A. It is important. I'm sure if your family member in Abuja calls you, that is in the pharmacy, he wants to buy so and so drugs, you have your recommendations. I'm sure we all do that. Can you give the pharmacist the phone? I want to speak to the pharmacist. Please give him Zithromax. Don't give him generic. Don't give him Zithromax. That is what I want. Give him augmentin. Give him this. When you're mentioning pneumococcal vaccine, give him Prevnar 13. That is what we want. Give him Prevnar 13 for your patients. This is just a summary of what we talked about for the extra 6 serotypes. We can see serotype 3, an important cause of pneumococcal, and it's also associated, like I said, with the acute otitis media that we see very often in our practice. Same thing, serotype 6A, very multi-drug resistance. Same thing with serotype 19A. So this is a real-world data effectiveness of this our pneumococcal vaccine. We can see with PCV7, over time, it was effective. We started experiencing the growth. Same thing you see with PCV10. Now look at PCV. Look at PCV13. Look at the death rates. Little, we have experienced significant reduction in IPD. That is invasive pneumococcal disease. It's important when you talk about medications. Medications are not literature, hearsay. You say medication will do this. Can you prove that it has done this? Yes. Prevnar 13, we say it prevents death that may result from pneumococcal infection. Yes. That is the data there. You can go and verify. 89% reduction as a result of IPD. Now, who is to take this Prevnar 13 vaccine? That's another important question. Who is to take this Prevnar 13 vaccine? For the pediatric population, that is standard at age 6 weeks, at age 10 weeks, at age 14 weeks. That is a standard regimen for immunization for our babies. Then a booster dose of PCV13 at 15 months, 12 to 15 months, or thereabout for your babies. Now, what we have in the national API at the moment is the PCV10. Oftentimes we hear mothers say they cannot afford PCV10. Now, I'm not here standing here telling you that PCV10 does not work. I never said that. What I've been saying is it does work, but the extra protection against respective serotypes I've made mention, this is an extra advantage you would get if your baby is getting PCV13. Now, in cases, because I like to be very practical, you're getting that from the government free. There are people that may not be able to afford 3 doses of PCV13 from out-of-pocket pay because we know the country is already hard enough. Now, no problem. You can take your PCV10, but it's very important that at the booster dose, you give your baby the best that is available commercially. You take your 3 shots from the government's PCV10, 6, 10, 14. Then at age, you cannot tell me that you cannot plan for the extra single shots from these ages, 6, 10 weeks, till 1 year, that's 12 to 15 months. You cannot plan for just 1 shot. Haba. If I have to be very honest, it's doable. We'll get to that, don't worry. You cannot tell me you cannot plan for just one shot. If you cannot plan for that 1 shot, you should not even get pregnant, if you ask me. You should not. If I have to be very honest. Would you want to give birth to a child and you don't want to take care of that child? It's not. I don't have a child yet, but I know that you should prepare to have a child and plan for certain things that are preventable. Now, for your child, for those of us that can afford, I'm sure most of us here can afford, Prevnar 13 at 6 weeks, 10 weeks, 14 weeks with a booster dose at 12 to 15 months for your babies. We can see the babies there, babies cradling. Then for teenagers that are living with certain underlying conditions, asthmatic patients, sickle cell patients, smokers, and all of that, they take just 1 shot. Just 1 shot. So that 20-year-old neighbor of yours that smokes, he needs just 1 shot and he's done. That 35-year-old hypertensive patient, just 1 shot and he's done. As long as the patient is 18 years and above. Then for most of us that are 60 years and above, whether or not you have any underlying condition, it is paramount you get your Prevnar 13 shots. Because you are 60 and you are not hypertensive, you think you are healthy. Well, you're healthy. Never said you're not. Because you're 60, you're not diabetic. You think you don't need certain drugs or you don't need certain vaccine. Age is your biggest problem. You can't run away from it. That you are 60 or you're 61 is already a problem. You think it's not a problem? It's a problem. So, for that your patient that is 60 years and above, sorry? Pardon? No, you're Yoruba, sorry. Okay, me, I'll soon become 60. I've actually taken my Prevnar 13 shots, so. So for your patients that are 60 years above and above, not just your patients, yourself, your wife, your husband, your father, your mother, these are all your Prevnar 13 patients. Now, this is what the Prevnar 13 vaccine looks like. It comes in a pre-filled syringe. You don't need to have to withdraw. You don't need to have to be bothered about a 2 ml syringe that is actually very long. It comes in a pre-filled pack, 0.5 ml. And I would like to still appreciate the leadership of the ACPN and the PSN because they have had a series of trainings on vaccination exercises. They have fully equipped the pharmacists on how to handle vaccines, how to administer vaccines, and all of that. And one of the steps in handling and administration of vaccine is when you get the vaccine, because it's a cold chain product, it's going to come out from the fridge, temperature of 2 to 8 degrees. You shake vigorously to obtain a homogeneous solution. Prevnar 13 is an intramuscular. Its route of administration is intramuscular route. You administer on the deltoid or on the vatul astellaris, but never on the gluteus. So you just administer single shots. Boom. 0.5 ml, and you're done. It can be administered in your pharmacies. You don't require the chew. I was hearing they talk about chew and all of that. If we are bringing up chew, then why did ACPN invest a whole lot in training pharmacists in the administration of vaccines? I was in panel 15. We had concerns about the law or legal binding for pharmacists to administer vaccines. And the ACPN chairman made mention of certain documents that protect pharmacists to administer vaccines. So you're very well covered legally. So these vaccines you can administer if you have been properly trained. A 0.5 when you shake vigorously, obtain a homogeneous solution. You just administer. Now, it is very important, even during the training, there were certain steps or information that was passed across. It is important to note that vaccines and medications, they are drugs. Oftentimes, people tend to think they are not drugs. But I don't believe a pharmacist to think vaccine is not a drug. Any substance that can elicit therapeutic change in the body, we'll classify that as drug. Does vaccine do that? Yes. Now, it is important to know that vaccine is drug. And if we're liking that to drug, what is one of the major side effects of paracetamol? Liver problem. Now, because paracetamol has liver problems, does that mean when your patient comes to the pharmacy for headache and there is a need to combat pyrexia or to combat headache, you shouldn't give your patient paracetamol? Does that mean you wouldn't give your patient paracetamol? You will still give them paracetamol. But you also tell them that it has the ability to cause this and that. So, when you experience this, not to worry. You're not going to die. Just tell them that. Now, with vaccines, there are possible side effects that is possible to be experienced. That's why we say possible side effects. Now, in the event that patients experience these side effects, there is no need to panic. And I'm happy all of us here experienced COVID and everything concerning COVID. When you experience this, when you experience that, not to worry. You are still fine. With Prevnar 13 vaccine, like every other vaccine, the most commonest reported side effect is where? Pain at the injection site. How many of us experienced certain side effect during COVID era that we had to take the COVID vaccine? Okay, how many of us had our COVID vaccines to start with? Did you experience any side effect? What was the side effect you experienced? You had high temperature, fever. Any other person? Okay, what was the experience you had? Numbness at your feet. Okay, what about you? Fatigue. Any other symptom we experienced? Are you people saying only less than 10 people took the COVID vaccine here? And some people did not still experience anything still. Okay, you felt sick, malazed, but you're fine now, innit? So with vaccines, there are certain side effects you would experience on a normal day. Possibly, I think the word is possibly experience. It doesn't mean everybody will experience it. Patient A might experience, patient B might not experience. But in the event they see these things, what are these things we're talking about? Pain at the injection sites, redness at the injection sites, swelling at the injection sites, headache, fever, muscle pain. Some people even vomited. Some people even vomited. Some people couldn't even leave their house for like the first 3-4 days. Some people had chills. Some people had high fever. These are symptoms your patient or yourself will most likely experience. So it's important that while this patient is in your premises and you're to administer this vaccine, you let the patient know that, mama, in the event you experience headache, no need to worry. It means say this medicine where you take, don't they do the work where you want them to do. It's as simple as that. In case you feel like say body they tire you or body they heavy you, make you no worry, just rest. After 12 hours or 24 hours, you will get yourself. It's that simple. During COVID, we saw people take the Pfizer COVID vaccine and they started experiencing dizziness. They started saying it's 666. Am I lying? Am I lying? I was in Kano during the COVID era. I was in AKTH and there were people that were saying they were not going to take the vaccine because it was going to affect their sexual libido. These are things that we see and hear every day. So it's important that as you're counseling these patients to take this vaccine, you let them know that in the event they experience this, it's fine, no problem. That this sexual libido they are talking about, this reproductive wahala, it's just a hoax. It's not true. So it's important. I'm not going to be there when you'll be administering these vaccines to the patients. You're the one that's going to be there. So it's important that these informations, you let these patients know. Can you help us with the screen? So how do we improve the vaccination exercise? You screen your patients. By screening is who should get Prevnar 13 vaccine, who should not get Prevnar 13 vaccine. That 35-year-old obese patient that has some form of atherosclerosis, that 19-year-old young lad that is asthmatic, these are your Prevnar 13 vaccine. These are your Prevnar 13 patients. After you have screened, you recommend the vaccine to them. After recommending the vaccine, some would accept, some would not accept. That is life. Then for those of them that would accept, you administer the vaccine. And after administration, as we know, it is very important for us to document that this patient has actually taken this vaccine. When your child goes for immunization at the health center and the hospital, they document it for them. Is that not it? You document it for them. Then all adults have immunization needs. That is standard. Every adult has immunization needs. Then using this halo approach for health conditions like I already made mention, diabetic patients, cardiovascular patients, lung disease patients. Those are your patients. Age, 60 years and above. Lifestyle, those that smoke, those that drink. Then occupation, people that work in the hospital, people that work in the community, people that work in camps, people that work in churches. These are your Prevnar 13 patients. And this is just Association on Immunization Practice, recommendation for Prevnar 13 vaccine. And we can see that patients, all adults aged 65 years and above are at risk. Then patients aged 19 to 64 living with these underlying conditions are your Prevnar 13 patients. Chronic lung disease, diabetic mellitus, alcoholism, sickle cell patients, HIV patients, renal patients, and its like. Then this is the recommendation. Then who are the stakeholders for adult pneumococcal vaccination? We have the internal medicine physicians, the cardiologists, the pulmonologists, then the medical staffs, the pharmacists. We are as important as they are. It's that simple. You most likely be the first person these people will meet before they go to the hospital. So in the hemisphere of adult immunization, we as pharmacists are very, very important to propagating this good news to the patients. Then, before I go, I would like to state 3 key facts about Prevnar 13. Prevnar 13 does not contain live bacteria. You cannot catch pneumococcal disease if you take Prevnar 13 vaccine. We used to hear that with measles vaccine, with oral polio. With Prevnar 13, you no go catch pneumococcal disease. For adults, it's a one-time dosing. It take you once now, and you're done for life. Prevnar 13 protects you against pneumococcal disease at any time of the year, be it winter, be it summer, be it harmattan, be it rainy season, as long as you have taken your shots. Thank you very much.
Can we do better for him? He's done very, very, very well. Don't go too far. Some years back, as the PTA chairman of a school, the school was going to run their inter-house sport. Okay, please, if you are the owner of this Subaru Tribeca EKY832EM, please kindly repark for him to move out. Please, if you are the owner of that car, you can kindly. Okay, thank you, man. And I got there as the PTA chairman, and the pupils, everybody were doing their thing, running around. And I remember my days in secondary school, 100 meters, 200 meters, flying boat, flying everywhere. And they said it's time for the PTA chairman to come and lead the parents. And I felt that once a runner, always a runner. And haven't been well kitted in my sneakers and jeans and t-shirt. Why not? This field looks like a familiar terrain. And we got there, and I think we were about 10 parents. On your mark, set. Before they said go, we've gone. And we're flying. And we got to the end anyway. I noticed I think I still remember I came second. Clap for me now. Why not first? I actually came second. And the point remains that I now saw stars. The whole place was turning like this. Turning, the whole world was turning. And I said, what is happening? So, as a sportsman, I just used Carifi. I stood a war. This trouble will pass me over. They didn't know what was happening. So when I came back to swagger. When I came back to the world, I said, Charles, I look by. By the time I got to the table, they gave me water. I asked for glucose. I drank the thing. They didn't know what was going on. 3 weeks, for 3 weeks, the muscles, the pain didn't go away. So it was that I knew that I was growing old, small. So if what Louis told you think is a joke, try what I tried. You will know that it's not a joke. Thank you very much. We are going to move forward now, and one good turn deserves another. So we are, just as we're talking, we just felt we should do something quickly. And this is the days of panel. We just came back from panel 15, panel 12. So we're going to start panel 1 today. So at this panel 1, we're going to have those who have talked about vaccination, and I coined it connecting the dots. Connecting the dots. Vaccination, connecting the dots. So we're going to have a panel set up. We're going to have 4 of us. Adekola, I hope he has not gone. Bianeba. I have Louis, who just finished presenting. Uche, Emzo. And I have the ACPN chairman, Ekato, pharmacist Ekato. Please, thank you. And I'm going to move this way. I won't carry it, I'll only move it. All right. Thank you very much. And I won't see stars today. So we have with us. Okay, thank you very much. The lady should see. Where is the lady? Uche. Okay. Okay, you. I thought I saw a lady that time. I need glucose. So honestly, I'm going to see something. Bola, please, in the midst of all of this, I need Pepsi. Jokes apart, I'm not joking. I need Pepsi. My daddy knows that I need Pepsi, Abby. All right. So permit me to welcome the chairman of PSN Lagos State Chapter, who will quickly give his opening address, as we also recognize the presence of the National Treasurer of PSN.
Let me appreciate our past chairman of this society. Let me also appreciate our mommy, a past vice chairman of this society, this branch, and also emeritus. Thank you, ma. So I want to appreciate everybody, past chairman of different, even technical groups and interest group. Let me stand on that protocol now so as to save time. When we were planning these masterclass sessions, let me tell you, it was intentional that we wanted to have a short day because we are thinking of tomorrow. And I've always been an advocate of that most of the time PSN meetings and PSN programs are usually very loaded. And for some of us, like Charles had rightly said, we are not getting younger. And most times, by the time we finish 5, 6, we are tired. You now want to come tomorrow for the opening ceremony. So it was intentional that we wanted to have a very short masterclass sessions. And I want to thank Pfizer and Emzo for keeping to time. But we now thought, well, let's still have a panel like this so that we can, we should not talk and talk. Always talking and talking. We should move on to action. Because that's actually what we are saying. Access to effective and safe medicine in Nigeria, a call to action. So that's why we deemed it fit that let's now look at the challenges and maybe shout out a roadmap so that we can achieve what I've given him Chief Tansi title, Chief Uche, I've said. And Luis also have also said, Professor Luis has also said. So that by the time we meet next year, today we have devoted it to vaccination. And thank God, one of our area of advocacy is actually working now. At least the federal government and they are recognizing the role of pharmacy. If they are to achieve, that universal, coverage in vaccination, the community pharmacy, and indeed all pharmacists, must be involved in this aspect. So thank you very much as we listen, because I'm being accused of talking too much. So I want to enjoy every one of us to listen as we shout out a roadmap to achieving this goal. Thank you very much.
This will be with you. Thank you very much, sir. Please, let's know that this is actually for us now. It's going to be an interactive section. We'll have opportunity to ask questions while they also give you responses. And you also contribute. If you have contributions based on experience and whatever you can offer. At this point, let me follow protocol by asking our fellows in the house. Please, can we just give the fellows of the society a round of applause? So, fellows, sir, do we have any media? Am I okay like this? Pardon? The second mic is with them. All right, I think it's fine. So, any contributions from us so far, sir? We can set the ball rolling, sir, from the fellows. Thank you very much. Call to action. We've had a lot of lectures, 1, 2, 3. Sincerely speaking, the last lecturer caught my attention. He actually spoke to me and spoke about my case, as it were. Let me just lay this background. 2019, some of us here would have heard and known about the story of my wife. While she was in lawsuit for 5 weeks, 5 solid weeks, I was actually sleeping on a table in one of the offices in the engineering department every night for 5 weeks. So what he said was very instructive and germane. And it's made me develop a prayer point. And that prayer point is that may Nigeria never happen to you. You didn't hear me? May Nigeria never happen to you. So, all depends. Expatiate. The negative side. So, don't worry. The one that will happen to you will become minister. So, it's just to buttress what he said. And of course, we thank God she came out of it, and today she's stable. But many people never had that privilege of coming back. So we should not wait. For me, I am going to take action. Louis, you have a bio over here.
Thank you very much, sir.
Now let's give the microphone to the ACPN Lagos State chairman, sir. As community pharmacists in Lagos, what is the next line of action? Vaccination. Thank you.
Thank you very much. Fellows, senior colleagues, Merit Award winners. As we all know, we started the vaccination mandate about, say, 5-6 years ago, when the past leadership of ACPN National decided to convene a training by involving pharmacists from outside of the country to train colleagues on vaccination. And before then, there was nothing on ground that we needed to have it. But when the next chairman took office, he decided to pursue that, and today we can gladly say that community pharmacists are now fully entrenched in the vaccination space. A lot of us have been trained, a lot of us have been certified, and a lot of us have started vaccinating in our pharmacies. In everything, there's always a rate limiting step. And the rate limiting step is the fact that health still remains on the concurrent list. If what we were doing is only on the exclusive list where pharmacy and pharmacy practice belongs, it would have been a smooth sailing issue. But we know that the Lagos state government, the state governments, are the ones that legislate on vaccination in facilities. And so for us in Lagos, it has been somewhat of a rate limiting step towards having community pharmacies fully involved in the vaccination stages. However, the good news is that from the top, with regards to the National Primary Healthcare Agency, community pharmacies have been recognized as primary healthcare centers. And what that means is that being a primary healthcare center, the fulcrum of primary healthcare remains preventive health. And the backbone of preventive health remains vaccination. And so, as long as we are part of that system, we are already into the vaccination space. And also having the idea that the newly approved TSTS policy, that's the tax shifting, tax sharing policy, has also entrenched community pharmacies in vaccination, also gives us that leverage to be able to push forward with vaccination services in the community pharmacies. So albeit we know that we are ready to go, so all we request, there is a saying that it is better to be prepared and not have the opportunity than have the opportunity and not be prepared. And in preparation, we are urging all community pharmacies to come out and get trained as vaccinators. If you know you are a community pharmacist and you have not been trained as a vaccinator, please, when the opportunity arises, which is going to come up very soon, please avail yourself that opportunity. Because the world is moving. Pharmacy practice is moving. Please, don't be left behind. Thank you.
Thank you very much.
Like the community pharmacy chairman have said, very soon Lagos State is planning a training program of vaccination, such that as many that are not yet certified or trained as a vaccinator, they will have that opportunity very, very soon. Thank you very much.
Thank you very much, sir. As scientists, we deal with numbers. How many of us are already trained in the house? If you are trained, let me see your hand up. Great. But this number is, Thank you, sir. So, ACPN chairman, sir, let's mobilize our colleagues for the next one massively. Emzo, what support will you give to ACPN in the next training that is coming up?
I was expecting a different question. I was actually expecting a very different question. Okay, we hold pharmacists as in our heart, and I think we've been consistently supporting every year. We actually take a large percentage of those that go through the training, and I know the support we actually do is full training and then part payment training. We actually pay for a certain percentage of the fee, where some people will actually pay fully for the fee. I think that is going to continue. The owner of the businesses are all pharmacists. They want to push this as an agenda. If it was possible for her, if you hear her and speak passionately, if it was possible to drive it to the presidency, to make this as a policy, she would. But the truth of the matter is, at the end of the day, it is us here that are responsible for that. If they say activity from us, then government is forced to actually do something about it.
Thank
but
you.
For MZO, every year we're going to support.
A round of applause for MZO. A round of applause. It's like we're going to support every year. Because call to action, the action thing here is that we must take steps, specific steps, towards achieving these goals.
Yes.
Now, Pfizer, we took your vaccines during COVID.
You didn't take Prevnar 13 vaccine.
That's where I'm coming now. What role will Pfizer play in this whole vaccination profiling for ACPN going forward?
As we all know, that Pfizer is an institution that is very much interested in bringing breakthrough that will change patient's life. And what breakthrough are we talking about? Reducing the incidence of pneumococcal disease. Now, not even from today, before now, Pfizer has been very big on collaborating with not just the pharmacists, with several healthcare practitioners. But bringing that question down to ACPN, we're very big on such collaboration. And as long as there is a room for such collaboration, I believe we would collaborate.
Another round of applause for Pfizer. The only appeal is when it is time for us to come for the trainings, please let's come in our numbers. Very essential. Now, my brother on event, Adekola, you spoke very eloquently. And I love the way you presented it.
Thank you, sir.
What do you think community pharmacists should do next?
Well, what I think we should do next is, number one, as pharmacists, we know a lot. We stand in a position in the healthcare professional family or community that is very unique. Why? Because we are the ones that are the first phase of interaction with patients. And like one of the speakers said, because cost of living is increasing, nobody wants to go to the hospital and so on and so forth. In the US, the CVS was the one that actually helped to facilitate COVID-19 vaccine. That's the biggest chain of pharmacy retail anywhere in the world. They have over 900 pharmacy outlets. If not for CVS, President Trump would not have succeeded in getting millions and millions of Americans vaccinated in just a few months. In fact, 10% of all the COVID-19 vaccines in America was facilitated by pharmacists. That was groundbreaking. Same thing is happening in UK. I think we are well trained, and I'm happy with what ACPN has been able to do. The chairman said 5 to 6 years ago, we've been on it. GSK did the neighborhood vaccination project over 12 years ago, and we've been trying to get pharmacists. So as an ex-GSK person, automatically when I came out of GSK, my advocacy was all about vaccination within the pharmacy space, and I'm so excited about what is happening. But I must say that the level of participation and deploying to use of what we have learned and be certified for is still not where it's supposed to be. So what I think we should do is just to start and not just keep talking about it. Just step out and start. But don't just start. Still get, consultation and advocacy advice. There are people, where I sit today is to consult and help people that want to start. I have a whole lot of pharmacies that I work with, both the chain ones and the single ones. The question is always that, why have we started this thing and nobody is coming to take the vaccine? All right? It's one thing to have the vaccine, and I would not advise you to go and store vaccines in your fridge. It's not advisable. Allow Emzor and Pfizer and other big distributors to help you keep them. The day you get people to vaccinate, please, if you get 2 people, it's a big success. You know why? For you to convince an average person to take a vaccine for what he has never had before, it's a difficult task. If somebody is having headache, he can walk into a pharmacy and say, I want paracetamol, even without you telling him what to take. Am I correct? But somebody that's not sick, that you are trying to sell something that is in thousands to, you have an extra mile to go. And so there's a way you sell those things, and I'm happy how he went about it. You need to convince people to take what they don't need right now, because you are talking of the future. An average Nigerian person doesn't think that way. Sorry to say, I'm not insulting us. We think about, what do I need now? That's why when you think about things like insurance and all that, you need to force people before they do insurance. Now, that's what I want. And you are talking of, I'm happy that the HPV vaccine, the human papilloma virus vaccine, which is for the prevention of cervical cancer, is now free. We sold it for over 12,000 naira per dose. Now it's now free. That's a magic as far as I'm concerned. But now, how many girls how many of us have girls and have actually taken our girls to take the vaccine? You will see that the figures never correlate. Ghana has an immunization coverage of over 90%. Nigeria is still struggling to be on 56%. A state like Sokoto has less than 7% immunization coverage. Lagos has about 82%. So by the time you bring out the average, Nigeria is always low, down there. Pneumococcal burden, just like he said, Nigeria is number 2. All right? Well, or number 3. Diarrhea, Nigeria is number 2 or 3, and so on. So if we don't get involved as pharmacists, there is no magic. Nigeria will remain on a low immunization coverage. Many poor babies or many more elderly people will keep dying. The next thing I want to talk about is adult vaccination. Adult vaccination is still very new, even in the US and everywhere. But one thing I want us to go on with is this. Vaccination is no longer a baby thing or a childhood or infant thing. It's a lifelong thing. What that means is everybody has a vaccine that he needs at every age. When your child is going to boarding school, there are vaccines he or she needs to take. When you start working in an environment, just like he said, occupation, it might make hepatitis A vaccine, for example. If you are working with a company that has to do with sanitation or whatever, that has to do with a lot of dirt, you need to take it. Typhoid, if you work in an hotel or whatever, so on and so forth. But the knowledge level is still very low amongst the people we want to give these vaccines to, or to put it in a very practical way, we want to commercialize. That's why we are in it. Am I correct? We want to make money out of it. The ones that will fetch us money are not the ones that the government is making noise about. They are the ones nobody is talking about. So that's where I come in, and I'm willing to volunteer when the training is ongoing. I'm willing to volunteer my experience and my whatever to make
Can
sure
we clap for that for him?
we get that done.
Volunteering is not easy.
So I want to implore everybody. I know the frustrations involved in starting out. I know. But please don't ever give up. Consult more. Talk to people. Immunization anywhere in the world is never done as a, one-man thing. You need people. You know about WHO, you know about UNICEF, you know about Melinda Gates, you know about everybody is involved. You know about these companies. Everybody is involved. So please reach out to people like us. We are here to consult and give you further expert advice on how better to know your target audience and the message you need to tell people that will make them say, yes, I want to take the vaccine. We've worked with so many pharmacists in Lagos, and I know that they can bear us witness to that. Thank you very much.
Thank you very much. A round of applause for him. Please, for all of them, a round of applause. Now, a quick one. ACPN. Please, you can put down your questions or you want to raise up your hand. ACPN, a quick one. Something came to my mind. Please come on. I did something that I think I can share with us. I have a database of my clients. I don't call them patients. I have a database of my clients. And on that WhatsApp group, I relate messages, information about healthcare and the rest to them. Now, using that WhatsApp group, I've been able to carry out community outreaches 4 times. Where I budgeted for 100 and I did about 190, 200. Out of it, we were able to do drug abuse, COVID vaccination 2 times. And incidentally, other ones that came weren't pharmaceutical related, but INEC. What do you call it? Registration for voters card registration, because my pharmacy is actually a polling unit. I have my ACPN chairman from Ogun State here. Please, let's clap for him. Pharmacist Ariyo Olusegun is with us here from Ogun State. So he can bear me witness of what I'm saying. Now, that database have been used, or is being used for, they ask me questions. Should we go for this? Is it good? Is it not good? If I say it's good, if I say it's... When it was COVID time, they asked me a question. Sir, have you collected your own? And I didn't see the message. Until I now went and brought them. So I said, all of us will collect. And it was then they believed me. So it is important that ACPN, please, the WhatsApp messaging platforms, Lagos PSN, I know we push a lot of, it's basically like a birthday platform. But let's push more of information that will be beneficial to us. Actually, it's good to celebrate birthdays, but if it is too much, you becloud the essence of these platforms. So please, that's my personal opinion, and I want to be held responsible for that statement. So, question, ma'am.
Thank you so very much for the opportunity. It's just a comment, really. I want to sincerely commend the Pfizer guy for his delivery. But I noted an omission which I humbly request you should correct. In one of the slides that was addressing the stakeholders, I noticed that you omitted pharmacists. And pharmacists are here seated. Their name was omitted. And I additionally want you to create another slide that would highlight the advocacy role of community pharmacists. That will give us a greater boost. Thank you so very much.
Thank you very much, Ma, for the stuff. Thank you.
That question was too short. I wanted to use the opportunity to top up, and you quickly finish the question. Any further questions before we move on? Young pharmacists, this is time for you to speak. You are looking at me. You that is looking at me, yeah, come. You, come, yes. Do you know why I called you? You look like my sister, so come. Yeah, come and make contribution or question.
Good afternoon, distinguished pharmacists. Good afternoon, fellows. I totally enjoyed the session. I must commend all the speakers for their contributions and advocacy role. And I must say that as a young pharmacist, I'm seeing the amazing work that my senior colleagues are doing. And I must really commend it because we are first liners. We are out there as community pharmacists. Patients come to us, and most of them, they have questions. And I can agree with the last speaker that talked about convincing them. So such a master class like this help us to gather knowledge so that when we go out there, we are able to give the right answer to their questions. And I think it's very commendable. Thank you, sir.
Thank you very much. Please, if you are a past director of any recognized hospital, come and take the microphone. We want to hear from you. You want me to call names? Okay. Okay, thank you very much. Please come. Let's use our time.
Good afternoon, fellows, pharmacists. Please, Pharmaceutical, when you were making your own contribution, you said that about the products, we should leave the storing, the safekeeping, to Pfizer and Emzo, while we do the convincing. Now, supposing you have just one patient, one client who needs the vaccine, would these companies be able to take the inconvenience for the sake of that single patient, bring this thing, vaccinate that patient, and then go back?
All right. Thank you very much, sir. Let me clarify what I meant by that. All right. Pfizer might not be able to do that because of their setup, or EMSO. I cannot speak for them. But what I mean by that, they also have distributors. All right. They are vaccine-specific distributors in Lagos. And I know one of the services they all run is to be able to deliver, even if it's just one vial, they will deliver to you. Why? Because vaccine storage is another story. Because it's advised that if you are going to store vaccines in your facility, you cannot afford not to know whether there was light overnight or there was no light overnight, because the moment you breach that that safety of 2 to 8 degrees, you might be giving the patient ordinary water, and you might be giving a false promise. The person might need the protection 5 years down the line. So it's just trust. Vaccine is about trust, because you don't know what was given to you until you confront the disease and you didn't have it. So because of that huge amount of trust that they put in us, it's better that we reduce the amount of vaccines we are storing, because you need more than NEPA or electric power. You might need solar, you might need inverter, you might need like 3 layers of backup. For the distributors, they have this level of backup. I know them very well. And I would just say that if you are comfortable that you are able to provide that backup, there's a temperature check you are supposed to have inside the fridge. You can't use just any fridge, and you can't store vaccines close to the sun. You can't even freeze them. So there are many things that I believe when we do the training, when we get exposed to all this, we can make a decision ourselves. But from an expert opinion, I think at this level where we are now having 50 people in a day being vaccinated, you can just tell them, we can give you the list of people you can call, and they will bring just 1 vial of hepatitis B to you when you need it that same day. I can assure you, I know that one for sure.
I was going to ask this next question before I give the microphone, that what minimum number of clients can a pharmacy have before your staff can come vaccinate?
I don't get the question.
Number. I'm talking about numbers now.
Okay.
Minimum. Before you can.
Okay, so like he said, the way Pfizer is structured in the country right now, we don't handle the product. We have designated partners and distributors. Over time, we got to realize storage, handling of vaccine had been a problem for community pharmacies. You tend to see a pharmacist say, I have just 1 patient that requires Prevnar 13. I have just 2 patients. Now, to take away that burden from such institutions, the partners we have can supply just 1 vial of Prevnar to your patient. Say you have an event, you schedule 3-4 patients on a Saturday, our partner can have 4 vials if that's what you want, or maybe 5 should in case somebody comes with an extra 1. Deliver it to you on the said day. Like he said, the storage of vaccine is a different ball game entirely. You're looking about storage costs, you're looking at about expertise in handling storage. Vaccine is not like paracetamol that's going to be on the shelf for the longest. It has to be in a specified temperature, 2 to 8 degrees. And like he said, trust. If the vaccine is in your car for 2 months, the patient doesn't know, but the patient is trusting you well enough to give him the best. And you don't want to break that trust. They say good name is better than silver or gold. So we have partners that we can link you up with. And
okay, fantastic. Can you make those details available to
yes,
PCPN?
yes. Yes.
You make details available. Okay, let's hear from just a minute.
I think the reason why this question is going towards this direction is an economic thing, right?
Yes.
Good. So everybody, the issue now is, what do you want to play for? Are you playing short term or long term? If you're going to be in the business, then you should be patient to start it. I believe the first person we actually started with, 2016, was this. We started the program of supporting with the kits and the vaccination, supplying the vaccination on the day. Take your time to create the awareness. Choose a specific date you want to do it. If you choose a specific date, people are aware that 2 weeks' time, 3 weeks' time, this will happen. For those that have interesting clients, you could actually insist on a commitment. It's based on that commitment that you work out the plan for vaccination and then get any slight extra. So if you take 3 weeks and you have 20 people, and you know Emeka, Toby, Ade might come, you probably plan for those 3 without commitment. So the person brings the vaccine to you, you sorted out the cost of logistics, you sorted out your own expense, and so it doesn't look unprofitable. Because I'm looking at some people's face while he was explaining, and I noticed that they were not calculating probably, will I be making a loss initially? So you've added all your costs, and then you now know, plus or minus, you break even, worst case scenario. So take your time, create the awareness, and then you can gather the people. If it's the one, two people, the distributors can sort out that for you. They can actually walk out, they'll come in, bring the vaccine exactly when the person needs it, and they get vaccinated. If you're not sure the person will be very serious, you demand he pays for it immediately, and then you come back so and so time to get vaccinated. At least you should be able to store the vaccine for a 12-hour period. Worst case scenario. There are ice packs available that can be dropped by the distributor or can be dropped by the companies here. And then you use that to maintain the temperature for the 12 hours. And then you administer. Thank you.
Thank you very much.
I just want to add, because COVID gave us like what we might call a case scenario amongst community pharmacists. And for those pharmacies that were vaccinating in Lagos, what was done was using the appointment structure. You don't just, because a vial of COVID vaccine is for 10 persons. And so once you have 10 on your register, you invite them. They book, and then you tell them, you call them at any time. So once they are 10, you tell them, come and take your vaccines at so time. That is what was done. However, there is this idea that we have always toiled with. Unfortunately, you know, one thing is to plan, another is to execute. And that still remains the COPA center structure. That has always been what we said we will use. There's supposed to be a COPA center, that's a Community Pharmacy Action Center. That COPA center was done, the pilot was done with USAID and PCN, COPA 1, COPA 2, COPA 3. COPA 3 centers were supposed to be centers that have vaccination storage capabilities in each zone. And so once they are available in each zone, you know they have it, you know the cost of the vaccine. Once anybody needs that vaccine and has shown commitment by paying, you just move to the COPA center nearest to you, which is supposed to be within the zones. In Lagos, we have 23 zones. And so that's the idea. So once these vaccines are there, you just go, pick the vaccine, administer, and return. And so you pay for what you use. And so that's the idea. So it's something we can discuss with all of us here to enforce and make sure it stands. We have a lot of pharmacies that can do this in many zones around. But we need to strengthen it, make sure it's workable, and then all the other parameters of training, availability, and then we're good to go.
Good afternoon, fellows in the House and colleagues. My name is pharmacist Miriam Egege. I want to add my voice to what we are discussing. It might encourage you. My own vaccine journey has been a long
Please, can we listen to her?
Down from the time of GSK. We were trained then and we were given chillers to study vaccine. The chiller was so big, so massive. We even made commitment before we were given the vaccine. I don't know if there's anyone from GSK here. I think we paid like 200,000 to 300,000 to get the vaccine at that time. And we were not properly guided at that time, I must say, because most of us that made that commitment and got the vaccine made a lot of losses. You know, we're creating awareness, we're having roll-up banners, we're having free screening. But the mistake we made then was that we got the vaccine in bulk for that amount at that time. And we made losses, like I said. And we're discouraged, of course, because if you have to throw away vaccine of that ton of money, you'd definitely be discouraged. But what we decided to do after then was to collaborate with centers, like he said. In fact, GSK then were the one that identified centers that we could work with at that time. Place well in Ojodu. If you are in Ogba Aziz or Ojodu Aziz, you can ask for place well. What we do now is, if you need vaccine, like they are all saying, we just quickly make a call to them. And within 4 to 5 hours, they will deliver. If you make a call in the morning, you can even call them in the evening of the previous day, and they'll bring it to you the next day. Then we would have obtained commitment from the customers. For example, we do typhoid very, very regularly. What do? When customers are always coming to buy typhoid medication, I will tell them, if you finish this one, just take your vaccine. It's even cheaper for you to be vaccinated than buy. I tell them, Ciprotab 2,000 plus, and you might even have a reinfection. Most times they don't finish it, so they have a reoccurrence very soon. So we identify those ones that come regularly for that particular complaint, and we advise them to take the vaccine. And believe it or not, they go telling others because they are getting results. So they go tell others. If we get the vial that contains 5 ampoules, like the chairman said, we say a family can come with your children because from 2 years you can take typhoid vaccine. So we get those 5 people committed and they pay, and we make a call to place well. The next day they deliver it. And before the training that we have had subsequently, because I have done like 3 training, and then I told myself I can vaccinate at this point. Before now, we're collaborating with hospitals. We not just send them to some doctors around, because we make friends with our doctors in our community. So we send them there, and they give them the vaccine. But now, we give the vaccine. We just get the money for 5 people for typhoid vaccine, which is the one we do very, very regularly. And then we give 5, and they are telling others because it's working. Because even myself, I was the first experiment. I experimented on myself and my family, and it worked fantastically well. Sometimes you need to try it on yourself. When you see how well it works, you have more confidence to sell it to others. So that one is working very well. I'm interested in what you said that the cervical cancer is now free, because a patient just came to me that they needed, and I still called place well, and they're giving me a bill of about 45,000 for the 3 doses. Okay, because I was actually very interested in that, because the bill they're giving me is for about 45,000 for the 3 doses. Okay, so I actually wanted to know if it's actually free for everyone, so that I can quickly hike on that, because even that bill is a little bit too much for the patient, and I'm telling her, okay, be paying bit by bit until you're able to complete. Then you cannot start the at least 1, 2, 3, you cannot start. That's what we are doing. So it's workable. You can try. Even at the moment, we are trying to sensitize about hepatitis B, because at the panel last time, Emda was there, and I had to do a thing about the hepatitis B. So we are trying to create the awareness. We're talking, and the next thing we did was to put a banner. Register for your free screening. That's where we are taking it from. Register for your free screening of hepatitis B. And they are coming. They are asking questions, and we're taking down their names. Once we have a certain number, we can now call on the EMSO to come and screen. And from screening, we'll be able to sell the vaccine to them. So those are steps that we can all take. Of course, we can all take. So you don't need to store the vaccine. Just collaborate with a center and try it. It works. And it will make you more visible in your environment, because I might be the only one doing it. Thank you.
Thank you very much, Ma. I think I'll see you after the... I think one thing we do as pharmacists, we are very innovative and we do a lot of things, but I'm not sure we are good at documenting and showcasing what we do. Now, if typhoid now, just like he said, antimicrobial resistance is on the rise because people take ciprofloxacin anyhow. And it has been shown that in the next few years, these products might not be effective any longer. Now, if she has been promoting typhoid vaccine, she can get enough data to convince world bodies like WHO that pharmacies are helping to reduce antimicrobial resistance because we have given this vaccine to 50 people and this is the result. So what I'm saying is, for every little thing you do, please document it and try and showcase. You can do something big and you don't even know it's something big. And sometimes it looks as if you are blowing your own trumpet, but you're not blowing your own trumpet. You are just showing your relevance. And the more we begin to showcase our relevance among the HCP community, the more valuable we become. So maybe I should just add that to that is a fantastic work, being able to prevent typhoid rather than treat typhoid. And what that means is you have actually increased the level of health awareness and health outcome in your community. And if all of us are able to do that, it will be a very big. I could remember we did an outreach with Redeemed Christian Church of God, the parish, 21 parish, and we vaccinated 500 girls. 500 girls against HPV. She was the one that facilitated it, Mommy Adeniro. And what I would just say is this. For every opportunity you have to do all these things, please make sure you document. We have a document. I'm just waiting to showcase it. And now that the government has started their own version, we'll be able to tell them that we've been on this and been getting this. Now you can imagine those 500 girls, wherever they are in the world, they are safe from cervical cancer forever. So those are the things we must be able to also establish, that we are making an impact, not just profit, but impact on the health outcomes of the society. So that's why we can be proud as professionals. Thank you very much.
Thank you very much, sir. Let's make visible impact.
Sorry, let me just say something. Pertaining to what he said, there's nothing wrong, and just on the side, there's nothing wrong in blowing your own trumpet. There's nothing wrong in blowing your own trumpet.
If you don't blow it, I will take it and blow it for myself.
Thank you for the opportunity. Good afternoon, colleagues, the fellows in the house, the company that presented. My observation is like is it a question of observation? The discussion you were just having was the centers was mainly on community outlets. I never heard any of you made mention of institutions like hospitals, how well you'll be doing with them. And I knew quite fine my name is Pharmacist Christopher Ogu. I'm the Secretary of Hospital Administrative Pharmacists, Lagos State. And in my institution where I work at, Federal Neuropsychiatric Hospital, Yaba, it's like one of a compulsory thing now for our patients. I majored in addiction. I work in addiction unit, substance abuse unit, where they manage patients with addiction. And we made it's a mandatory issue now in my unit, in the sense that our clients must be on vaccine. They do. It's EMSO that it's not. I don't think whether the company or the person repping for, like a presenter. Somebody used to come. We called the person on phone. It started from our department. All of us taking the vaccine. I know my director, Mrs. Peters, that was there, knew how all of us got the person and made it an issue of the hospital-based thing. And now we are speaking of adult vaccine. I'm hearing of it. Now, I don't know. I would not felt you put same part. I don't know. And I wouldn't know whether you have other hospitals I'm relating with. So my concern this time around, that I know EMSO is doing something great with us. Even the last program we had at Mushi General Hospital, from the chairman of the local government, all the councillors, they insisted that they want to, and we got the vaccines for them. But this adult vaccine, with the presentation we did today, I saw the relevance that we should push more to ensure that institutions, hospitals, both private and, because I'm concerned, both private and public hospitals can get it, and it was a very nice information that I got today. Thank you very much.
Thank you very much. Let's welcome the immediate past National Secretary of ACPN.
Good morning, House. I just want to add to what we have been talking. And I only want to say something on what? Documentation. All the things we are doing, or we are talking here, the user are saying, if we don't document it, anything that is not what? Documented is what? Not what? Done. That's the way they say it. And the ACPN National have made it very simple. How many of us have keyed to ourselves healthserve.com? Healthserve.com is a documentation tool which ACPN at the last national conference was adopted, even in Lagos before the Asaba. We just concluded few weeks ago. And the HealthServe is as simple as what? ABC. I know yesterday I saw my facility, I saw close to maybe when I was sitting down up to like 10 to 11 clients added to my system, added to my documentation too, just in my system, in my phone, in my laptop, and even what we have, the tables were imported, both the labeling machines and all that. So what am I trying to say? We do a lot of things in community pharmacy, but we don't document it. That is our major problem. We don't document it. So let us try to key in to the health serve this time around so that you can showcase what you are doing. All the services you are rendering there, you can showcase it. We can also use it for advocacy and all that. If you remember that COVID vaccination was flagged off in community pharmacy because of what? What we showcase, what we say we have done. We gave them the number of people that was trained. We gave them the number of people that have vaccinated. Up to 100 persons have been vaccinated in community pharmacy nationwide through COVID. We presented this data. If you could remember in this last conference that somebody, Dr. Gribert, came from National Primary Care Development Agency. The essence of his coming was to train on routine what? Immunization. All those routine immunization, because they have key in, they have understand, yes, we can do those services, and we have started documenting. NGOs are also key in to community pharmacy because their complaint was, we don't report, we don't do this, we don't do that. So, but that's simple tool of documentation to key in every services we are providing in community pharmacy. We can what? Report it as simple as ABC. Thank you. Let us key in.
Thank you very much. At this point, we just want to... Last one.
Good afternoon, distinguished colleagues. I just want to say something. You know, the last but one speaker, that's pharmacist Ugu, mentioned something about creating awareness. And I'm concerned. You know, just as pharmacists, most of us heard about all this adult vaccination here. What are the key into it? And I was discussing with pharmacist Tuche, after his presentation, that I belong to an organization that does medical outreach on yearly basis. And we do a lot of screening, and we have been involved in, screening people for hepatitis. Those who are negative, we vaccinate them, give them the 3 doses. But we are having challenges. Even with all the, talking to them, some of them will take the first dose, second dose, you vaccinate 100 for the first dose, by the second dose, you are having maybe 50, then the third dose, the number is increasing. So what are you doing? Because it's a great concern. Now I've heard about the Pfizer presentation. Even when you are ready, you are giving them free. Because at the outreach, we'll tell them it's free. You are not paying for it because we pay. Definitely, we won't get the vaccine free. So but get it free, they are still not taking it. So I'm concerned. The companies, what are you doing about, creating this awareness and making sure that people do get vaccinated? Thank you.
I think while you answer the question, you also add your parting shot.
So I would say, I think I will phrase the question, what are we doing? We've spoken about the awareness we do. When we spoke, we also talked about, we actually take it to the market. I know there was a period that it was just only markets that we actually went to, and we took time to do those programs. And then for the pharmacists, maybe I forgot to add, once you are doing your awareness and you have compiled a certain number, we also help out in sending SMS. We do it centrally. We actually have a central system for that. And so that they can get alert and know that your next vaccination is so and so day. At the end of the day, the flyers are there, both digital and physical. The staffs are there that actually go to communities, to groups, religious organizations, market associations, and create the awareness. But at the end of the day, I think people trust certain people. That is why I came here to advocate. That's why I came here to solicit for participation from the pharmacists. People trust certain people. If I'm a stranger and I walk up to you to tell you about hepatitis B, you have a perceived notion about me. You want to collect my money. But a pharmacist that is actually going to you or you go to a pharmacist and speaks to you about hepatitis B. There's no you want to collect my money because you have been collecting the money already. So this one will also be collected if that's your own fear. So that's the reason why we came to solicit for pharmacists to participate in this awareness. At the end of the day, what we're going to do is what we've been doing, but in a larger form. The materials to create the awareness we will provide. The kits to help screen will provide. Because if you go to the hospitals and to the gentleman that actually spoke about, do we participate in the hospital? The lady that actually started that program in your facility was Ogochukwu, and she handed over to somebody else then that handed over to the present person doing it now in your facility. We do to the hospitals. We partner with the hospitals to actually do the programs. But we've noticed something, because when you sample opinions of people, they tell you, I don't want to come and spend money on card. That's one factor. I don't want to spend money. The hospital will be expensive. That's the mentality. So the pharmacies or the pharmacist or the pharmacy outlet is presumed cheaper, generally. And this sampling was not done to 10 people, it was not done to 100 people. I will just stop at that number. It was done to thousands. And the pharmacist is cheaper. Okay. So if the customer has spoken, you'll be a fool not to go and pursue what he's telling you to do. And that's why we are participating with the pharmacist. Our own is call us, let's see seriousness, and we'll support. And the seriousness, the demand for seriousness is not much. We want to see when we drop the flyers, you will start gathering names. We want to see that those people have made a bit of commitment. And the rest, we'll leave it to us to do.
The demand for seriousness is what? Seriousness. Okay. Louis.
That was a very, very wonderful question from my senior colleague. What has Pfizer been doing in the area of vaccination? Pfizer is here in the masterclass. Before now, I'm sure most people didn't know that there was a need to take pneumococcal. That there was a need to take pneumococcal vaccine. Awareness, advocacy is one of them, and we are doing that, and we believe there's more work to be done, and we are always here to support in whichever way you feel you need our support. Thank you.
Okay. Well, thank you very much.
Okay. Thank you very much. I'm no longer in the companies, as it were. As I said, I'm ex-GSK, but I remember those days. My biggest budget was promotional materials. I mean, materials to promote awareness of the disease. I used to spend, not to exaggerate now, in the minimum of 10 million to just print. 10 million of those days, you remember. So we used to have leaflets on each disease, typhoid, hepatitis B, HPV, and all that. We used to print them in millions to be very. But just like he said, after we print them, our code in those days used to just be doctors and nurses. But thank God that pharmacists are now in the fold. I can assure you and guarantee you that with the little I still know about Pfizer and Emzor, any awareness leaflet you need, you can get it free. Roll up banners and so on. You just need to talk to them. Presently, what I do now is to connect healthcare professionals together with the general public, and I have a podcast that runs almost every month, and we talk about disease awareness. We did one during World Immunization Week. We did one during World Hepatitis Day. We are doing one this month. We are doing one during the pneumococcal. We are partnering with them and so on and so forth. I'm linking the whatever. So there is a lot I am doing, my organization is doing to raise awareness. It's easier to raise awareness amongst ourselves than to raise it amongst the general public, because the general public is so huge. Let's take the HPV, for example. How many girls are in Nigeria that need the HPV vaccine? You're talking of our population is more youthful, right? and we have 200 million. So, and we are told that 70% of our population, 70% is you. So you can imagine how many people can we talk to as a company. So that's why we need everybody. If you personally can reach 1,000 people, and all of us can reach 1,000 people within 1 month, that's a lot. So rather than asking just what the companies are doing, I think we need to say, what are we doing? Because until we collaborate, we really cannot get it done. So those will be my closing remarks. Let's keep collaborating. Let's keep talking about how we can take this forward, and let's keep doing the little we can do to make sure that we are acting on what we know. Thank you.
Yes. Well, in closing, I just want to urge colleagues to take vaccination as one of their core mandates as pharmacists going forward. Because the truth is, that is where the money is right now. If you want to make money as a community pharmacist, you should be thinking about vaccination, because everybody is selling your drug anyway. So, in the bridge, in the buses, at the marketplace, everybody is selling it. So what do you have to lose? Online. So just go to where uncharted territories, and vaccination seems to be it. And finally, I want to remind us that we're still on air for the rest of the week. Tomorrow we'll be at Echo FM 97.9. Yes. On Friday, we'll be at Metro FM 97.7. Tomorrow, 9:15. Friday, 12:30. Then on Saturday, we'll be at Tungba FM. That is a Yoruba station. If you're in Lagos, we'll put it there. Yes. I just spoke one today at Bond FM. So on Saturday, we'll be at Tungba FM at 7 a.m. So please let us tune in. That is the only way we can reach the masses. And we are doing as much as we can. One of the ways, yes, we can reach the masses. And we are doing all we can to maximize that avenue. So join us, publicize it. We'll put it everywhere on PSN, ACPN platform. And let your clients, customers, family listen in to promote the profession. Thank you.
Please, on Sunday, join Charlie FM. I will communicate it on the platform. Can we give the panelists a round of applause? A round of applause. Fantastic one. Please, the first thing is, like they say in Hausa, the Hausas will say, when you say you have mangani, they will tell you, have you used it before? So, get vaccinated so you can vaccinate. So, please leave here. By the time you are coming next time, we want to see the numbers increasing. And we believe that the chairman, the call to action is to move this masterclass to the next level. So that when we come back, we'll have every cause to laugh. Thank you very much, and have the best of time.
Yeah. Once again, I want to really thank the panelists, especially EMZO and Pfizer. We have actually enjoyed your sponsorship of the masterclass. And please help us give a round of applause to EMZO and then Pfizer, because it is by their good gesture that we are able to hold this. And I want you to pass the message to the management that in future, like we have said, we still want this collaboration, so that by the time, the truth of everything is that, you see, we are the only professional, and I'm bold to say this, that care about the populace, about the people. Because I've always been telling everybody that if the Nigerian populace knows what they are missing when the pharmacy content is not part of the healthcare delivery, they would have protested much, seriously than anybody will have think about. It is not going to be like all this, because when I and my mommy that we were at one forum, when people were talking about the interventions, people die anyhow in this country, and because there is no deterrent, there is no lawsuit, impunity, and we will make sure that we document all these things. So once again, let me thank Pfizer and EMZO for this very, very kind gesture that you are even extending to us. Thank you very much. Please extend our warmest gratitude to your management. I also want to thank my brother Kola. He has also been a serious advocate of vaccine, and we will get there by God's grace. Lawrence, thank you very much. Continue on Tungba. Which one is Tungba FM? Then maybe you will now move on to Charlie FM on Sunday. Thank you. I want to thank everyone for attending. Please make sure you eat and eat very well, because we have sufficient food for everybody. Please, if you are not served well, please ask for more. Tell them that the chairman told you that you can ask. And so I want to thank everyone, because it's not easy to come out in this weather. Thank you very much.
Thank you, sir. ACPM, please don't forget, it came to my mind. House for documentation. I don't know, but I just think about it. Not necessarily editor-in-chief. Editor-in-chief is in charge of publication. Why this person will be collating data. Thank you. Chairman and the panelists, please photograph with... and please wait for a short presentation by Pfizer. So while you are eating, you can just use one hand to welcome Frank. Frank from Pfizer, please come around. You can, if you can clap. If you cannot clap, break your plate.
Thank you very much. Okay. Good afternoon, everybody. I'd like to stand on the already well-established protocol, thanking PSN Lagos for having us here today, and also for all of the broad conversations in and around vaccination. It's important that we know, like one of the speakers during the panel section mentioned, that vaccination is a business of trust. These people trust us as pharmacists. These people trust us that just anybody cannot walk up to the burden of stroke. It's up to 5 times higher in patients with hepatitis that we'll be discussing in a moment. It is something that can multiply the risk for those patients that would need vaccination. Take, for instance, a patient that would require pneumococcal vaccine. Very likely, the risk factor that patient will present to you will be a cardiovascular risk condition, can be atrial fibrillation. Or some other times, this patient may even be presenting with a swollen leg due to a deep vein thrombosis, running a risk of throwing an embolus, or would have already had a recurrent deep vein thrombosis, making the lungs less capable of doing what it has been doing for all those many years. Or it could very well be an elderly person. While all of this may sound like so many risk factors in one, an elderly patient that is being, and if we don't also help them by making sure they are also on the best of medication, we're doing a very fantastic job when it comes to giving these people supplements, making sure they are well protected with the best of supplements for each category. I think for our medical colleagues, most of the supplements they get to prescribe are those that are in front of them at the moment or available in their facility. But in every pharmacy, they have a broad range of supplements, and we are really at the forefront of getting tailor-made supplements for patients that walk into our pharmacies. And we can also very well do that for oral anticoagulants too. We can also make sure that every healthcare professional that seeks our counsel or that we have to come across or engage in performing our roles as pharmacists gets the best oral anticoagulant for your patients. Like I mentioned, the risk of stroke, which is a cardiovascular risk factor that can very well indicate vaccination for your patients, is up to 5 times higher in patients with atrial fibrillation. Here's one thing that pharmacists can do, whether this patient is presenting to you in your community pharmacy or you're encountering this patient via your online consultation platform or simply in a hospital pharmacy. One of the things you can do for this patient that run cardiovascular risk is a CHADVAS scoring. And this goes a long way to document the beautiful work that pharmacists do every other day. Now, a CHADVAS scoring is very simple. For patients who have congestive heart failure, representing the C, they'll have a CHADVAS score of 1. I'd like to run us through the scoring first of all. A CHADVAS scoring has a different score for male and different scoring for female. So when a patient has a score of 0, it's considered that the patient does not require oral anticoagulation. When the patient has a scoring of 1, it's considered that this patient should be considered for vaccination for oral anticoagulation when they are male. But when they are female, you say they may not necessarily require anticoagulation. Now, when these patients have a scoring of 2, you start considering oral anticoagulation. The same way you see a patient come to you and they've come down with pneumonia before, or they keep abusing a certain antibiotic, and you quickly indicate vaccination. That's the same way pharmaceutical care can also be well practiced in your facility when there's a CHADVAS scoring for this group of patients, and they come in every other day. There's hardly a day in a regular community pharmacy or in a hospital pharmacy that you will not meet patients across these health conditions. When these patients have a CHADVAS scoring of 3 or more, they are certainly going to need anticoagulation. Now let's run through the scoring. Congestive heart failure patients will have a score of 1. Now I take it when will have a score of 1. For hypertensive patients, they will have a score of 1. For patients who are aged above 75 years and above, so take for instance, this patient is presenting at 65 and above, and you've known this patient is vaccinated, they've gotten Prevnar 13, they've been protected against typhoid, they've had other vaccines as they need to. And it's obvious for every patient that wants to vaccinate, one thing is clear, they want to live a better quality of life. And helping them know or get their CHADVAS scoring is also your own commitment to that patient in ensuring that they enjoy that better quality of life. When these patients are greater than 75 years and above, they have a scoring of 2. I remember a scoring of 2 puts the patient at a place where you are considering anticoagulation, or it's recommended that you consider coagulation. When these patients have diabetes, they have a score of 1. Now, these factors, you could have one or two of them you could have more than one of them in a single patient. Another thing that can also multiply their risk and requiring them to need anticoagulation is when they have vascular disease. Maybe they've had a myocardial infarction before, they've had peripheral artery disease, or they've had an aortic plaque. These people present as just any patient that could come looking for maybe a beta blocker, coming for their regular antihypertensive, and these patients are your everyday customers. they make up for the reason why you stock those medication. And they are part of your commitment to show this patient that we are not just here to make sure you get your medication. We're also here because we want to make sure you are healthier, is to quickly do a chart-var scoring for them. So this is something you can even find an online format for, or you can have it printed, and for each of your patients that lives in the community around, just do a chart-var scoring for them, and they will be grateful when you were able to give them directions moving forward. Now, I did mention that stroke is a major risk, is a major challenge in this part of the world. And then one will bring it down to where we are in sub-Saharan Africa. We find out that we actually have the highest burden of stroke worldwide. While we consider vaccination as the in thing, stroke is actually a major burden that we see every other day. So we find patients who are either at risk of stroke or already would have had stroke before, and they are actually maintaining their life and trying to recover motor function from a stroke they've had. For example, the stroke incidence rate in sub-Saharan Africa is about 316 per 100,000. To drill down and bring that further home, say the size of this environment, Ogudu, we may have just about 100,000 persons living in this environment, maybe less. Imagine 316 persons presenting to the closest general hospital as patients at risk or already having stroke. That is a very huge burden on that clinic, and it's a very busy clinic already. It gets even worse when you consider the fact that there's a 1 month fatality rate in about 40% of these patients. So for patients who already have stroke, the chances that about 40% will not make it past the 1 month mark is there. So it calls for a concerted action as pharmacists, as the first line of response when they come to get their medication, as the very first patients, as the very first caregiver they get to encounter most of the time, to quickly step in and recommend to their HCPs or direct them when we get the chance. Now, while we look at our oral anticoagulant at Pfizer, Eliquis is a top-of-the-line oral anticoagulant available to us today. It is the world's most prescribed oral anticoagulant. The good part is it used to be a medication that was available to patients who come from abroad. It used to be one of those foreign medications they will bring to your pharmacy and say, do you have this? But now it is very much available. In fact, before Pfizer launched Eliquis to be available in Nigeria, it used to be available through pharmacists who take the extra pain of sourcing it for these patients, maybe through parallel import or through some other means. We take the extra pain to make sure these patients get this medication so they can live a healthier life. But now the good news is it is available, and even better information that we need to have this afternoon is that getting PI for your patient may not even help them so much. Number one, because having PI may not tell you may not be able to trace the source of that medication. But getting the registered Eliquis or Apixaban in Nigeria guarantees you that you know where it's coming from, and it is traceable to Pfizer Nigeria. Another reason why registered Eliquis in Nigeria is also something that you should do for your patient or consider for your patient is the fact that it's actually more cost effective. Yes, it is more cost effective. An average Eliquis parallel import may cost your patient around at least 70,000 or more for a month's dose. But for the branded Eliquis registered in Nigeria, it's actually a lot more cheaper than that. A pack will go for around 40 to 45,000 depending on where they are getting from or depending on where you are sourcing from. Maybe you are sourcing directly or sourcing from a third party. It just really depends. But 40 or 45 is the mark, is what you will consider what you put at the end price for your patient as of today. So you see that we'll be doing a lot more for our patients when we get Eliquis from the right source. But drilling down, let's also see some of the advantages of this medication. So as pharmacists, we are better put in a position to have this conversation around the world's most prescribed oral anticoagulants and make sure that our patients are on the safest and efficacious medication available to us when it comes to oral anticoagulants today. We know that Eliquis is not a prodrug, so you do not have to activate it in the body. We know that it is 50% bioavailable. It has a very fast onset of action, 3 to 4 hours, and the patient is okay. You do not also it's actually 12 hours. It's time to maximum plasma concentration is 12 hours. So in 12 hours, your patient will have had the maximum effect from the oral anticoagulant. And of course, it's dosed twice a day. So your patient is covered for every single hour this patient needs it. You also consider that it is 27% renally cleared. In this time and age where we find patients coming down with all sorts of renal impairments, maybe due to lifestyle, maybe due to ignorance, maybe due to what they have to ingest or what they have to take, we know that renal impairment is a thing now that we have to actually bother about. So for a patient, we don't have to wait for this patient to be renally impaired or for the signs of renal impairment to start showing before we advise our physician friends, before we advise that hospital closest to us, or that facility that relies on us for their stock of medication to switch to a safer option for all of their patients. And then again, of course, apixaban, the mechanism of action is that it's a direct, highly selective, active inhibitor of activated factor 10. To put it directly, this is where factor 10 sits between your extrinsic and intrinsic pathway of the coagulation cascade we got to know about many years ago in school. Apixaban and another molecule, rivaroxaban, actually sits in that particular place, able to act on activated factor 10. And this puts Eliquis at the very center of anticoagulation in patients you get to encounter. When Eliquis is only 27% renally cleared, it is the least renally cleared of all oral anticoagulants available to us today, making it the safest option for renally impaired patients. I think of that doctor sending a patient to you, and you see that this patient is getting some other supplements to support their renal function. You see that this patient is getting some other medication to improve their renal function, or they are even getting some other medication that directly points them to some of the disease risk factors we look at in the CHADVA scoring. We see that Eliquis is one of those options. You should be able to call their doctor and recommend to them. 27% renally cleared, but that's not all. It actually has multiple routes of excretion. Others may be liver, direct intestinal, biliary, and having a very small renal clearance makes Eliquis safe on the kidneys and safe for renally impaired patients. But like I said, we do not have to wait until renal impairment sets in before these patients are protected. I've seen it as a joke many places online that somebody said, if I can sell one kidney and I'm making $150,000, if I sell two, how much will I make? It was a joke, but I don't think anybody wants to sell two kidneys. I mean, what I'm trying to point out here is that the cost of a kidney can be very, very expensive. We do not have to wait till these patients have renal impairment or they have to rely on Eliquis because it puts little or no burden on the renal system. We can very well start protecting their kidneys right from the very first day they need oral anticoagulation. Then we look at the approved indications for Eliquis. Some patients would need Eliquis because they've undergone hip or knee replacement surgeries, or because simply they have been admitted in an orthopedic ward and they've had orthopedic surgeries. So you find them we also know that Eliquis could also be an oral anticoagulant useful in preventing stroke in atrial fibrillation patients. So reducing the risk of stroke and systemic embolism in non-valvular atrial fibrillation patients, for treating deep vein thrombosis, for treating pulmonary embolism, also to reduce the risk of recurrent DVT and PE following initial therapy. So one of the many times I've had doctors have to call on me to help them source or to direct them to the closest pharmacy they can get Eliquis for their patients is when sometimes these patients have failed on one oral anticoagulant or another, and the next place, like they say, when all else have failed, the only place you can really go is up. But the message here today is that as pharmacists, we can better direct our sister healthcare professionals on the need to actually start from the top, that oral anticoagulant that offers the best protection and the better safety option for your patients. So to reduce the risk of recurrent DVT and PE following initial therapy. So when these patients have had the DVT before or they've had a previous stroke and you've done their CHADVA scoring, it is important that you tell these patients, call on your doctor. Can we talk to your doctor together? Can I advise your doctor? Maybe they're already on another oral anticoagulation or another oral anticoagulant. You could very well have a very good clinical conversation with their doctor on the need to improve their safety and get an even more efficacious oral anticoagulant so they don't get to fail on others, then run to Eliquis. It's important they actually get the best from the very first day. You also find out that these patients will benefit from Eliquis when they have undergone hip or knee replacement surgery in treatment and also so that they don't get to encounter DVT or PE. There are so many studies out there, some of which you can even find by simply googling what Eliquis is. One of the things you will find is that it is the safest and also offers better efficacy than many other oral anticoagulants available to us today. But one of those studies conducted on knee replacement patients actually showed a 38% risk reduction when it comes to total VTE. So when we say Eliquis is the safest oral anticoagulant available to us, it is not just in text. It is actually in data that has been collected and gathered well over time, and studies are being published every other day that supports this. We also have, when it comes to safety, Eliquis is also safe. This particular study compares it with enoxaparin. Enoxaparin that is in fact an injectable, and Eliquis still stands out having a lesser major bleeding. Bleeding is a major factor you consider in oral anticoagulants. In fact, when a patient is on oral anticoagulants, one of the things the doctor or even you as the healthcare practitioner that will come to meet for counseling when they get their medication should be worried about is, do they know when to report when they bleed? Are they safe enough on this medication? Would they know? The risk of bleeding is imminent. It is there every other time. But with Eliquis, you can have better sleep and better rest when that patient is on Eliquis, because the risk of bleeding is far lesser compared to even IV medication. And then again, there are several other studies. This other study also compares in hip replacement surgery, and you see a 64% reduction in risk of bleeding. This shows superiority of Eliquis over even enoxaparin. And this particular one actually compares it's a bridge therapy. Sometimes doctors get to bridge Eliquis, get to bridge enoxaparin and warfarin, and 69% reduction in the risk of major bleeding actually goes to show how safe it is in your patient practice. You get to find there's so many other studies that also points to how safe and efficacious apixaban and Eliquis is for your patient. So when next a patient comes to you with a prescription for any other oral anticoagulant, it's important that you get to understand where this patient is coming from. Do a CHADVA scoring, and if possible, have a conversation with the doctor behind that prescription on the need to place this patient on the safest and the more efficacious oral anticoagulants available in your practice. Then a key message that we'll have to take this afternoon as I round off is that Eliquis is that oral anticoagulant that you can use on your patient beginning from day one. In some other medications, you have to bridge. You have to start on an IV, then eventually switch to orals. With Eliquis, from day one, you can start using it, and the benefits are immense. Also, that Eliquis do not require. It has a fast onset of action, and it has a simple dosage regimen. I'll show you for atrial fibrillation patients. The recommended dose is 5 milligrams morning and evening. It's just that simple. By the time you have to do a dosage reduction, which of course they have to meet 2 of the A, B, and C criteria, age, body weight, and serum creatinine. If they meet at least two of these criteria, there's a need to do a 2.5 milligram, a 50% dosage reduction. However, when there's serum creatinine, when there's severe renal impairment between 15 to 29 ml per minute, you can very well also do a 50% dose reduction. This is important for pharmacists to know, as this goes to show that we are at the very top of our scientific knowledge when this patient is before us or when these physicians get to interact with us. Also important is the dosing for DVT and PE. To prevent DVT in treatment of DVT, you find that Eliquis is simple to initiate and use. 10 milligram twice a day for the first 7 days. The doctor can taper down to 5 milligram twice a day for the next 6 months. Moving forward, they can do a 2.5 milligram twice a day. And this is all they will need to do to protect their patient. And this is key information they can get from you as a pharmacist. However, for prevention of DVT, as they will find in orthopedics and every other patient that's bedridden for a period of time in the hospital, 2.5 milligram BD is important. Just to also emphasize that age, body weight, and renal impairments are advantages that Eliquis offers. You do not have to do a dosage adjustment for this group of patients. As you find, comparing with other oral anticoagulants, with rivaroxaban, edoxaban, Eliquis has the least renal clearance. Hence, the safety we keep emphasizing in renal impairment patients and in other groups of patients. You also find that Eliquis dosing regimen is particularly simple. It has a simple dosage for a fully functional renal system from day 1 till, of course, if the patient's renal function does not improve, till the very window of severe renal impairment, which we usually start from 30 to 15. That's when you get to do a 50% dosage adjustment, as I discussed earlier. Before that, you simply maintain the dose, and it is that simple. For other oral anticoagulants, as you find, you would have done 1, 2, or 3 dosage adjustments, which may not be very easy for any other doctor to remember. But with your guidance, they can very well stay on the safest line of action by using Eliquis from day 1. And I don't have to bother about adjusting the dose when the renal function says this, adjusting here when it says that, until, of course, they do a 50% if this patient does not get better. So it is that simple to use. That's the message. Importantly, too, cost is an advantage of Eliquis. For rivaroxaban, for example, branded rivaroxaban, properly imported branded rivaroxaban, your patient will need an average of 65,000 or 60,000 for a month's dose or a month's supply. But for Eliquis, like I mentioned, 40 to 45, and they are good to go. That's a cost saving of about 20 or 25,000 in a month. That is actually a reason to, if you really want to support these patients, help them put the money back in their pockets. That money could be channeled into many other medications that they will need, or into the supplements that you feel will help them support their health. And then again, just to remind us that it is simple to switch. For those doctors that will ask you for how to switch their patients from other oral anticoagulants to Eliquis, this is just a simple way to switch from warfarin. Is just simply to discontinue, wait till the INR drops to less than 2, and of course you can start Eliquis. For other oral anticoagulants, you just discontinue and start Eliquis as the next dose. And that is very simple. Just to emphasize and recap on all I've said, for Eliquis, safety, efficacy, and cost advantages are among 3 top reasons why you should choose to recommend Eliquis for that patient, that physician, and that healthcare practitioner, that hospital that's beside you or that relies on you for their medication supply. Because indeed, it supports not just the patient, but also helps them live a better lifestyle. Thank you very much for your time, and do have a wonderful conference.
Please, I'm sorry. I want to know why is it necessary to use it during diabetes in diabetic patients? I can understand the case for atrial fibrillation, stroke and all that. Why necessary in diabetic patients?
We are not saying that Eliquis should be used in diabetic patients. What we are promoting is that when these patients come to your practice, if you do a CHADVA scoring, it gives you how at risk. It tells you how at risk these patients are of stroke when they have atrial fibrillation. So a patient could have, atrial fibrillation is actually quite common. Like I showed you the data that in a size of 100,000, about 315 patients would have atrial fibrillation. In sub-Saharan Africa, that number may even be higher because we have a very unstructured way of gathering our data. So the data may not be saying the reality. So when patients come to your practice, they are coming to look for they're coming to get their regular medication. Maybe they're coming for their bisoprolol and other medications they use during atrial fibrillation. You can simply do a CHA2DS2-VASc scoring for them. And diabetes is one of those markers you will find to know that, to place them correctly at the very point where you know if they will require anticoagulation or not. I don't know if that puts clarity to it. So it's not a medication for diabetes. It is a medication that will support your practice. The CHA2DS2-VASc scoring will help you place your patients, and that's where diabetes comes in. It will help you place your patient in the right place where you can put a call to their doctor and advise them correctly on when to commence oral anticoagulation. I don't know if that answers the question. Okay. I don't know if there are other questions. Oh, thank you. Sorry, I didn't get that. Oh, why that may not be available? In fact, there are online formats that you can quickly use. You can also have printed ones that are available for your superintendents and other persons around you that they can quickly pick up and use. CHAD, or just if the slide is still up, VASC. So if you just Google that, you'll find several copies. I'll just show you. Okay. So it's actually correctly pronounced as CHA2DS2-VASc, but of course you can simply say CHA2DS2-VASc or CHAD, and once you Google that, you find a lot of samples. You can even find printable formats. You can find an online format to use. Okay. I don't know if there are other questions or around this while I round off. Thank you very much.